Hello.
Hi.
Vishal,
Yes.
I think have a case. I'll just check up. I'll send you a message on the system. Yeah.
Oh, please,
I'm
please.
just-
Yes, yes, sir. Yes, sir.
I've got an interesting and a different type of case. I think I'd like to show that.
Oh,
But
yes.
I'm just checking whether
please.
I have all the slides. I'll send you a message on the system. Yeah.
So I'll on the chat group, I'll mention the sequence, exact sequence of
Yeah,
cases,
yeah.
how and
Okay.
when they are coming up. Perfect. Neeraj, over to you. Ashok, over to you.
Yes.
Hello.
Ashok, are we ready?
Yeah.
So I'll just introduce, okay?
Yeah.
Everyone, we welcome you to Ortho TV Online BSS Spine webinar. Today's webinar is on primary spinal tumors with our moderator, Dr. Vishal Kundnani. And before we start, nowadays we have a disclaimer slide, which would like you to read. We would read a little bit about it. We would like to thank all our faculty for sharing their knowledge and expertise with all, especially in such challenging times. We wish all our audience a healthy and safe days ahead, and we hope these webinars add value to your time. These webinars are dependent on internet speed, which may be at times unstable. Please bear with us for any issues with internet. All information and academics discussed in the webinar are sourced by the speakers from reliable sources. However, please use the information provided in the webinar only after confirming with standard teaching. The opinions in the webinar are for academic purposes only and are not a substitute to evidence or experience. The speakers, neither the portal is responsible for any untoward event caused due to information presented in the webinar. We also thank Sun Pharma, the makers of Hydrophos, for bringing us this webinar. Over to you, Dr. Vishal Kundnani.
Dr. Sai.
Yes. Good afternoon, everyone. Myself, Dr. Saijot Rao. Welcome all participants, panelists, and speakers. Welcome all the delegates. Thank you, panelists, Sun Pharma, and Ortho TV for organizing this webinar. Today's topic of the session is primary spine tumor. It's not meds, it's the primaries. Just have questions. So, what are the challenges in primary tumors? Second is, why is it important to diagnose them early? Third is how to suspect on MRI, which is the TB and which is the tumor. How to do a biopsy in tumor patients? Is it mandatory even when the patient has the frank neurodeficit? Fifth is differential diagnosis of tumors as per the age of the patient. Principle of management of the primary tumors. What are the different options of surgeries and reconstructions? Is surgery always possible? And what is the role of SBRT or radiotherapy? So I would like to ask Dr. Vishal Kundnani to moderate the session and introduce us to the panelists, please.
Hi, good evening. Thank you, Dr. Sai. Thank you, Neeraj, and thank you, Ashok, for organizing this. And at the outset, let me just introduce this session to you. This is a session on primary spinal tumors. Spinal tumors basically are of two broad categories. The ones which originate primarily in spine and create mechanical or neurological symptoms due to disturbances in the spinal physiology because of the pathology there. Or secondary tumors which arise somewhere else in the body and spread to the spine like metastasis, or for that matter, systemic issues which can then spread to the spine. So we are not going to be talking today about secondary tumors or spinal metastasis. We are going to be primarily discussing about primary spine tumors. And mind you, primary spine tumors are not uncommon. They are fairly common in current practice. And we are going to be showing some cases to you. This is going to be an interactive case discussion session. At the outset, let me just bring out the panelists for today's scenario. This is the Bombay Spine Society webinar, of course, supported by academic grants from Sun Pharma. I would like to invite Dr. Sameer Dalvi, who is the senior member from Bombay Spine Society and a consultant spine surgeon. He's going to be the senior panelist with us today. He's also going to be showing a very, very interesting case in spine tumor, primary spinal tumor. With us, we have Dr. Mihir Bapat, one of the pioneers in spine tumor management. He's currently at Nanavati Hospital. He's the head and director of spine services there. With us, we have fellowship trained in spinal oncology. With us, Dr. Kedar Degaonkar, currently at Dinanath Mangeshkar in Pune, and he's a full-time consultant there now. With us, we also have the young Turks, Dr. Manish Kothari and Dr. Priyank Patel, who are also consultant spine surgeons, both in Jaslok Hospital and Lilavati Hospital, respectively. Welcome you all, the panelists. And I'm going to be moderating the session, bringing out questions on the behalf of delegates, primarily on primary spinal tumors. So on one hand, we will have surgeons talking about surgeries in primary spinal tumors. How can surgeries change the way and the morbidity of these tumors? How can we increase or enhance the quality of life as surgeons in when patients have primary spinal tumors? We also would like to emphasize and bring out the fact that many a times surgeries are not good enough. They are not complete to take control of all the problems of tumors, and recurrence can be high. Sometimes we have to have adjuvants like chemotherapy and radiotherapy. And in the recent times, probably in the last decade, SBRT or stereotactic or localized radiotherapy, particularly for primary spinal tumors, have taken a lot of precedence, not only in preventing the recurrence, but also as primary modality of treatment, be it GCT, be it ABC, be it plasmacytomas, or be it hemangiomas. And also, of course, there are various other tumors, including PNETs, where radiotherapy has really been a primary choice of treatment, wherein not only can surgeries be completely averted, but also the magnitude of surgeries can be brought down significantly. And today we have with us Dr. Shankar V, the consultant interventional radio oncotherapist from HCG group of hospitals, and he has a huge experience in spinal radiotherapy and SBRT in primary and secondary spinal tumors. We are going to have him shortly here, and he'll be talking to us about what, when, how, and why about primary spinal tumors and radiotherapy. So just to bring out some slides on primary spinal tumors. Uh, Primary spinal tumors comprise more than 43% of all spine tumors that we see. And they have been broadly defined into three basic types. Benign tumors, they can be ones which can arise from cortical bone or bone marrows. They can be ones which can come from fibromuscular tumors like myxomas or sarcomas, or they can be neurological like PNET or endocrine tumors. There are aggressive benign tumors like GCT and ABCs. We all know about them. And of course, there are malignant tumors, be it in kids with Ewing sarcoma or osteosarcomas. Even eosinophilic granulomas are malignant tumors, happen in kids. They can also be in the form of malignant osteosarcomas or hemangiomas in adult patients. And in elderly patients, chordomas, plasmacytomas, and myelomas are again malignant primary spinal tumors. And we are going to be seeing cases of every single type, which is going to be in front of us. The list of primary spinal tumors is big. Unless the mind knows them, the eyes won't see them. More often than not, we have been seeing lesions in spine and often just shoving them under the carpet under the name of either tuberculosis or pyogenic spondylodiscitis, which is not only the commonest diagnosis in spine, but also commonest misdiagnosis in spine. So if I had to say that 20% of patients diagnosed with spondylodiscitis have one or other kind of tumor, it will not be an overwhelming statement here, because that's the truth of the fact that 20% of tumors get completely missed at the first sight of contact by the specialist surgeons treating these patients. And remember, all these tumors, they usually don't come and say that I am a tumor. They only present either as an incidental finding, or they may come up with very subtle mechanical symptoms like simple back pain and neck pain with normal looking x-rays, which can lead you or mislead you to diagnose them either as normal people or normal patients with only mechanical back pain, which will lead to a misdiagnosis of these tumors, resulting in these tumors coming up at a later date with a wider or a bigger shape, and which will require a more bigger surgery with a higher morbidity. And remember, these tumors with a high index of suspicion can be diagnosed quite early in the phase of their evolution. And that is what we are trying to emphasize here, that these tumors are present in a wide format. There is a wide DD of these tumors. However, the radiological findings may mimic tuberculosis, and so every radiological picture should not be thought of as a tuberculosis. Why? Because radiologically, these tumors may either be lytic or sclerotic. They can dodge you. However, a lytic lesion can have a wide variety of pathologies, and that's why GCTs, ABCs, plasmacytomas, even myelomas or hemangiomas all would present with a common lytic kind of radiological presentation, and very few tumors would give you a sclerotic lesion. Some may actually have a mixed pattern of presentation on radiology. How do we understand on MRI that this is a tumor and not an infection per se? There are some findings. There are some radiological markers which should click to your eyes. The moment you see them, you cannot miss them. Of course, a radiological triad of soft tissue, spondylodiscitis, and bony destruction with constitutional symptoms makes you think that it is tuberculosis. But mind you, not all discitis are tubercular in nature. And to be very specific, ballooning of vertebrae, vertical split fractures, cystic lesions, erosions in the bone, posterior elements involved, disc sparing lesions are all very, very specific markers of spinal tumors. And whenever you see them, please understand that you are dealing with an aggressive spinal tumor and you're not dealing with an infection. So don't just shove away into considering them as only infections or TB. Remember, most of these patients will have either an intact vertebrae with ballooning and all these signs, or some of them may have a pathological collapse, which happens usually with a trivial fall. And that is why any trivial pathological collapse of spinal fracture with a minimal epidural spread, with cord compression, end plate injuries, and tumor signs present, minimal spread around, should raise a high index of suspicion of being a tumor rather than infection or anything. And when it comes to principles of management, I think nothing would overemphasize the need of biopsy, that you need to have biopsy in hand even before you think about any plan of management, because unless you have confirmed the diagnosis, even in patients with frank paraplegia, you may want to have a biopsy to plan your surgery well. Remember, the basic principle of management is to reverse the symptoms that patient is presented to you with, and also to prevent the recurrence, which purely depends on how wide the margins you're getting. And of course, many a times adjuvant therapies are come very, very handy, like radiotherapy we are going to discuss about today. They come very handy to prevent recurrence in these patients. Remember, all this has to be done with minimal morbidity to the patient. And so to summarize, principles of management include biopsy, embolization, surgeries, reconstruction, stabilization, but to emphasize the most on diagnosis being the paramount. Spinal biopsy is mandatory in every spinal lesion. In kids, please have a very, very high index of suspicion. There can be a wide variety of lesions in kids like eosinophilic granuloma, ABC, lymphoma, and tuberculosis. In young adults, remember, no tumor is less aggressive. All the tumors in young adults are extremely aggressive, be it GCT or plasmacytomas, and many a times hemangiomas. If they are symptomatic, they can be very, very aggressive. PNETs are extremely aggressive tumors. And in elderly patients, the prognosis is very poor if they are not diagnosed well in time, like chordomas and myelomas. And that is why early diagnosis is the paramount in managing these tumors very efficiently. Like in some of these patients, eosinophilic granuloma in a child presenting with a normal looking X-ray. And remember, most of these patients, when you have a definitive diagnosis, may not require aggressive treatment, like many of these are going to be discussed now. I'll be running through these. So just to summarize the principles of management, we are going to be seeing them in case-based manners, where Dr. Kedar Degaonkar is now going to come up with his first case scenario. Kedar, if you can pull out your slides here while I summarize the principles of management of primary spinal tumors. Remember, the primary spinal tumor principles of management are only 5. Confirmed diagnosis. It's absolutely paramount to plan the treatment well, whether it is surgical versus non-surgical. Remember, the morbidity of the surgery can be brought down by embolization. In most of the primary tumors, it may be required, and that's why diagnosis is very, very paramount. Planning the surgery, which has further steps into it, we are going to be seeing by our specialist presenting today. And of course, adjuvants like chemotherapy and radiotherapy may come very, very handy. Remember, primary spinal tumors have an inherent nature to recur back very early in the nature of disease, and that's why a long-term follow-up is absolutely paramount. So I will stop sharing here. Kedar, would you like to come up here with your slides here? We already have Dr. Shankar V with us. Welcome, Shankar. Kedar, are you with us, Kedar?
Yes. I'm just pulling it up.
Okay. So let me just ask a few questions. Let me start with our senior panelist here, Dr. Sameer Dalvi. Dr. Dalvi, what are the commoner tumors that you have seen in last 10 years, sir? What are the commonest tumors that have come to your practice in last 10 years, which can be clubbed as primary spinal tumors? Dr. Dalvi.
I think if you count myeloma, then myeloma is by far by a huge margin. I would say 90% of the tumors are myelomas.
Okay. In elderly, let's catch up on age calendar. In young kids, what are the commonest tumors you come across? What are the commonest tumors in young patients less than 50, and what are the commonest tumors above 50, sir? Like you mentioned, myeloma.
In young kids, of course, eosinophilic granuloma and Ewing's or PNETs are very common.
Right.
Then in the sort of adult group, you would be looking mainly at GCT or ABC.
Right.
If you calculate, if you count osteoid or osteoma as well, then maybe you can count that as well. They're fairly common actually. Right. And if you calculate, if you count hemangiomas, then hemangiomas as well. If you count hemangioma as a primary tumor, then yes, but we have seen aggressive hemangiomas as well, which are actually primary tumors.
Right. Right.
And then in the elderly, myeloma just beats everything. Myeloma and lymphoma beats everything.
Right. Like Dr. Dalvi, you just mentioned that you have been seeing all these patients. Would you please help us to understand what are the commonest symptomatology of these patients that walk into your clinic, age-wise bracket, if you can divide? Like a kid comes to you, what are the symptoms that you see? And a young guy comes to you, what are the symptoms? How should we be having that high index of suspicion in mind that this can be a tumor? Clinically, basically.
See, honestly, they all come in as back pain. And it would depend on at what stage of the disease they come in. So it is very varying. I mean, you would get a whole bunch of patients who come in with little back pain in the sort of society where MRI is done more. Like you do a lot of MRIs. MRI is done early. In that socioeconomic group, they are really diagnosed much early. In a different socioeconomic group of poorer patients, less aware patients, they would then come much later with severe pain because of collapse or sometimes with neurological deficit.
Right. Right. And usually when you see a neurological deficit, would you really think about it? What are the signs, radiological signs, which really catch you to think about tumors primarily rather than thinking about anything else as your pathology? In a patient with neurodeficit, a patient in your emergency room with paraparesis, and you have to start thinking, what is the cycle that starts in your mind?
I think anyway, if a patient comes with neurological deficit at a very early stage, you do tend to get an MRI. Of course, you will get an X-ray as well, depending on where the patient is, how the patient is. And if an X-ray shows a solitary lesion, central collapse, you would be more, with the pedicle gone in the AP X-ray. You would think more in terms of a tumor, which may be primary or secondary. We don't know at that stage. The
Right.
MRI, you look for certain signs. You look whether the disc is spared. You look whether it is iso-intense versus hyper-intense. You
Right.
look to see whether the posterior elements are involved or not involved. You
Right.
look to see whether there are other skip lesions, absence of abscesses and other soft tissue. And this
Right.
gives you an idea that this may be a tumor. But I don't think unless and until you have a biopsy, you can really say whether this is a primary tumor or a secondary tumor.
Right, right. Manish, let me ask you on this question. What are the lesions when you surely ask for a biopsy, or biopsy is the standard norm in your practice, or there are specific radiological findings when you think more in terms of biopsy? Your voice, Manish, your voice. Yeah. Unmute, please.
Hello.
Yes,
Can you hear
Manish,
me?
we can hear you. Yeah.
Yeah, see, anything where basically you have to have an MRI before you intervene with any form of intervention. So that MRI will give you some lesion. Now you have to, on the MRI, you'll have a fair idea whether this is looking like a tumor or is it looking like an infection. There are many times that they are both, there's a very gray line between the two, infection versus tumor. So these are the times when you're anyways looking at a biopsy. So we always anyways looked at the findings on this X-rays as well as MRI. And you also have to get CT scan done. You have to talk to your radiologist what they are thinking and what you are thinking. You have to match your clinical presentation with the radiological presentation, and anything suspicious you have to biopsy. And as a general rule, whenever I biopsy, I always send for culture, histopath, everything, so I don't miss anything. And basically, it will be the radiology which decides when to do a biopsy.
Right, right. Thank you, Manish, for being a very, very pertinent.
Madam.
Dr. Amir's word has been echoed here often, that spinal biopsy is mandatory in this world of spinal lesions. Keep your eyes open, keep your mind open. Unless until your mind thinks that primary spinal tumors are common, you will only be misled in terms of calling every lesion either an infection or a TB. Dr. Mihir, I mean, it's so common to get carried away by MRI findings, which are very, very typical more often than not. For example, I have seen so many lesions which have soft tissue abscess also, disc is also involved, and there is a collapsed vertebrae also. So how do we really differentiate? Like a patient comes to you with an MRI and only back pain and shows all these findings of abscess also, bony destruction also, erosive lesion also. How do we really as surgeons think in lines whether this is a tumor or this is a TB? Are there any radiological markers to think in those lines?
See, a lot of radiological markers have been sort of highlighted when it comes to a case of a tumor. But when you see a mixed pool, that means you really are not aware whether it's a tumor, an infection, or a fracture. Then it becomes very difficult to identify these typical radiological markers unless they are standing out at you, like a soft tissue lesion which is consistent and there is a stippled calcification inside it. So if there are telltale signs of a tumor, you know it's a tumor. But at the same time, without a biopsy, nothing can be planned. Nothing absolutely.
Right.
So you require a definitive tissue biopsy.
Right. So do you mean that every lesion should be biopsied?
Absolutely. Whether it's an infection or a tumor, every lesion should be biopsied.
And in your practice, what are the commonest tumors that you have come across in last decade?
In terms of the primary tumors, in order, the giant cell tumor.
Age-wise, less than 20 years, 20 to 50, and 50 to 70.
Okay, so it comes to first would be an osteoid osteoma, an osteoblastoma, then comes an osteosarcoma, chondrosarcoma, then it comes to giant cell tumors, aneurysmal bone cysts, hemangiomas, plasmacytomas, multiple myelomas, metastasis.
Tell me one of these lesions which have a very typical radiology which can be called pathognomonic.
The only thing is we have been able to say with relative confidence in terms of a chondrosarcoma or an osteosarcoma.
Right. I think the message again and again the echo is that there is a fair number.
Very, very rare.
Yes. So it's absolutely impossible to diagnose a tumor purely based on MRI. And many a times your biopsy may look like negative, but it may have some tumor receding in. And okay, let me come Dr. Samir again. Dr. Samir, is it possible, like in lytic lesion, it is said that the diagnostic yield of a CT guided or any biopsy is far less in lytic lesions, and most of the tumors present like lytic lesions. So do you think that in patients with tumors, the chances of having a negative biopsy is quite high?
Actually, tumors have quite a decent yield. I think the ones which don't have a good yield are like ABCs or hemangiomas, where they just get blood. But
Right.
especially, but normally for tumors, there's a good yield. And if you have a good radiologist, because many of the times, a combination of the MRI and the CT already gives them a very big clue to the diagnosis. And then if you take the biopsy of the right area of the soft tissue or the junctional area, then they do tend to give we get see. I think we need to get a very pretty good idea of what the disease is. We don't have to know exactly what it is. Like for instance, if we can differentiate between a myeloma and a GCT and a TB, it's enough for us to make a treatment plan. Now within that, what is said as a GCT sometimes does come out as an ABC or vice versa. But the treatment plan doesn't radically differ between the two. What we do need to know if there is any malignant change there. But that too may come out only after you take the whole specimen out. So I think you get enough idea on a biopsy to be able to plan your treatment at that point.
Right. Priyank, can you please tell us how and what instructions do you give to your radiologist or your biopsy guys? What are the specific instructions that we all should, as delegates, should be giving to the guys who are doing biopsy?
So, so once I discuss with them what I'm thinking about, and if I've got, so usually I tell them that they need to take a wide core. They can't just go and aspirate. A wider core is needed, and multiple site biopsy should be tried within a particular tumor, because it could be heterogeneous. You could have calcification at one place and soft tissue in the other place. So multiple different, like if your center is like a tumor center, at the same time, you should have a pathologist ready. So as soon as you get a biopsy, a part of frozen section should be sent across, because a lot of times we get that review back from the pathologist that the sample was not adequate. So usually these points, and of course, if there is a PET scan which is available, then that's a very good tool, because then you can talk to your radiologist and do a PET guided biopsy. So take the sample from the part which is maximally lit up in your PET scan.
Right. I think all these points come very handy. Remember that the diagnostic yield in lytic lesions is supposed. Yes, Kedar, please. Kedar, your word on that.
I have one more thing which I consider when I'm thinking about primary spinal tumors. I usually want to get the orthopedic oncologist involved because they see tumors on a day-to-day basis, and we see the primary tumor irregularly. So how will this tumor behave biologically? And the pathognomonic appearance of a tumor, it's best to have an oncosurgeon, orthopedic oncosurgeon, as part of your team from day one, so that he can advise you about the biology of the tumor, the management of the tumor. So at Hinduja, we used to have Manish Agarwal. So he used to always be part of the team from day one, before even we plan the strategy for management.
Right, right. Dr. Mihir, one quick question on that, and we'll summarize it and we'll jump on to Kedar's slides there. If a patient comes to you with paraplegia or paraparesis with a spinal lesion, would you still be doing a biopsy and waiting for the report to come, or you would jump in and do a surgery and intra-lesional surgical biopsy you will be depending upon? Dr. Mihir Bapat. I think Dr. Mihir, we have just lost him for a while. Dr. Dalvi, can you take this question? In a patient with paraparesis?
What is the question actually? Sorry, because if you don't say my name, I don't listen. Sorry.
Yeah, in a patient with paraparesis and a spinal lesion, would you still be doing for a biopsy and waiting for a definitive surgery to be done later after the biopsy is there, or you would do a definitive surgery and an intraoperative biopsy will be done?
A lot depends on the clinical situation and the radiological picture. If you have a patient who has, like for instance, you can have various scenarios. So let me just tell you, if you have a rapidly evolving serious neurological deficit, rapidly evolving. So suppose he's like in the last 1 or 2 days, suddenly he's gone down from normal to grade 3, 4, and he suddenly, grade 4, 3, and suddenly coming down to nearly 1. I would study the radiology very, very carefully and maybe jump into the surgery, making sure that I do an angio before that. Even a combination of MRI, CT, and angio will give you a pretty good idea as to what the disease is, right? But anything other than that, I would like a biopsy before, which means suppose somebody comes to me with 2 weeks history of grade 3 power, I don't think that another 4 or 5 days is going to make much of a difference. Or if somebody again comes with 2-3 weeks history of grade 0, again, why to this thing? But I must say that MRI, X-ray, MRI, CT, as well as the angio also, all together give you a very pretty good idea of what you're going to be dealing with.
Right. I think this gives the summary of this question, that surgery in tuberculosis and infection is a completely different ball game, whereas surgery in a tumor is a completely different ball game. A surgery in a tumor essentially may require a biopsy to plan it well. Otherwise, not only will you be probably doing a incomplete suboptimal job in a patient thinking that it is tuberculosis or infection, while it turns out to be tumor later. And that's why you may want a biopsy for sure before you plan a definitive surgery, number one. Second, sometimes these lesions which look like TB may turn out to be vascular tumors, and your surgery may actually be a recipe for further neurological worsening. And that is why, like Dr. Samir mentioned, unless and until there is a compelling reason to jump in for a surgery which is like rapidly evolving scenario, a progressive worsening of neurology in front of your eyes, you should wait for a biopsy to come, and a CT angio of that lesion will tell you about the vascularity of the disease. And if you have to really jump in that situation, you may actually want to do an angio before to prevent yourself from landing up into these situations. So these are some very important insights. And like Dr. Priyank and Dr. Manish mentioned, that biopsy, though in lytic lesions, have a low diagnostic yield. However, the diagnostic yield, even in patient with lytic lesion, can be increased by various ways that we just discussed, having a frozen section available, trying to have lesion, the biopsy from the periphery of the lesion, trying to have multiple punches, trying to see which part of the lesion is active and getting a biopsy needle probed there, and trying to have multiple lesions. Remember, these samples that you bring out have to go in 2 different bottles. One is saline and one is a formalin, because unless you put in your sample into formalin immediately, immunohistochemistry of these biopsies cannot be done. And that is why it is mandatory that 2 samples minimum should be taken. One goes in saline, one in a formalin. Only if you have fixed them in formalin will the IHC reports be able to tell you the type of tumor if the biopsy turns out negative from a saline. And of course, always think Swadeshi, like Modi ji mentioned yesterday, think that you are in India and it may still be a TB. And so you may always want to advise, apart from histopathology and IHC, always do a culture sensitivity for these things. So we'll move on to Dr. Kedar Degaonkar now. Kedar, we would like to see your case, and then once your case comes up, we'll go and follow the sequence of cases to Priyank, Dr. Dalvi, and Dr. Mihir Bapat, and then we go on to Dr. Shankar for radiotherapy and its role in spinal tumors. Kedar Degaonkar, please.
Yes. Can you see my screen?
Yes, we can see your
screen. Can you see my screen?
It is starting. It is starting. Yeah. Yes, we can see now.
Okay. So thank you, Vishal and BSS for this opportunity. And I'm very keen to listen to the radiation specialist, Dr. Shankar, as to how he would help us in managing these cases. So I'm going to present a case of an L5 chordoma, which we treated a couple of years ago. So the presentation was a 44-year-old male police officer from Uttar Pradesh. He presented only with back pain for the last 4 months, which was progressive in nature and which was also present at night and also in the daytime. It was mechanical type of back pain in the daytime. The pain also started radiating in his left leg in the L5 distribution, and that was going on for 1 month. So he contacted local doctors in Lucknow, and eventually he turned up in Mumbai for further management. So this was Vishal, his X-ray, standing AP and lateral views, which didn't look very remarkable, except for the pedicle of the L5 on the left side.
I think yes. Now we can see the X-ray. Yes.
So the X-ray is standing AP and lateral view of the lumbar spine, which did not look very remarkable, except for the pedicle of the L5 on the left side did not look as clear as the right side. So it was hinting towards the winking owl side, and that was the suspicion we were having. So I think we will go ahead with what we did in terms of investigation. And I think everybody would agree at this stage that he definitely needs an MRI scan.
And there is no
a plain MRI. There is no neuro deficit. Only thing, he has left-sided L5 radicular pain, progressive for the last 1 month, and back pain for 4 months, and an X-ray which shows or indistinct pedicle on the left side of L5, and an MRI scan. This is a stir image coronal section, which show high signal in the L5 vertebral body with some maybe damage of the.
Right. So while we catch back upon Kedar, I think his signals are lost. He'll come back in a while. Manish, may I start with you now? A 44-year-old male with left radiculopathy and an MRI showing a lesion which involves L5 vertebrae. What are your primary thoughts into this?
This looks like clearly like a tumor. At least whatever that one image is showing, it doesn't look like an infection or anything. But this is pathological. This is not a normal finding. This is not a normal variant. It looks pathological and it is symptomatic. So I am looking at characterizing the lesion. What exactly we are dealing with. I'll ask for. I think Dr. Kedar is back.
Yeah. Let him come back. While his slides come up.
I'll be asking. Basically, you have to characterize the lesion further. So you will be talking to your radiologist. What does it look like? And you'll be planning further investigations. Get a local CT to look at the destructions as well. If possible, probably if it is indicated, we might be looking at a PET scan also, and then planning a biopsy accordingly.
Right. Priyank, primary insights into the lesion. Priyank, what all is already running into your mind, and what are you already thinking to do for this patient? This patient is only 44, male with only left leg pain and some back pain. No pathological fracture, no trivial fall, just this X-ray. It doesn't show much, and the lesion is quite encapsulated. Yes. What are the things that run into your mind?
So right now, what I can see is there's one lesion there in the lumbar spine, and it looks radiologically as a tumor because of the ballooning and one pedicle involved. Here I would see, and it's about to rupture. If you see, the posterior border is already ballooning out. I would like to first get the biopsy done, and along with that, get a PET done, so that once we have the histopath, we can then start planning. Like, do we directly jump into surgery, or do we have additional neoadjuvant therapy that we give before jumping into surgery?
Right. So one PET CT scan to understand the spread of this tumor apart from localized area to some other place is important. We also surely want a biopsy to understand what kind of lesion this is. Dr. Mihir, are you there with us now? Would you please elaborate what is your diagnostic plan and why would you want to do all those tests in this particular patient? We already know that PET CT scan to understand if there is any other lesion here and there, and also we would want to know about biopsy. What are the other investigations that you would do at this stage, Dr. Mihir?
No, I think when we are talking about primary tumors, the two main investigations are going to be a PET scan and a biopsy.
Right.
Other investigations come into the play mainly when you are talking about a metastatic lesion. But in this particular case, an MRI, a CT scan, and a biopsy are the three main investigations that will help me plan.
MRI, CT scan, biopsy, and a PET CT scan.
Yes.
Dr. Dalvi, why are we doing these? What is running in our mind? Already are we thinking about surgery? Are we starting planning of surgery? And if we are planning surgery, what are the things that you look into a MRI and a CT scan, which will be helpful to plan a surgical or a treatment plan for this patient? Dr. Dalvi.
So obviously we are going to do something for this patient. He has come, he has a lesion. This is not something which is going to go away by itself. So we have to diagnose. I would add a PET CT to this as well.
Right.
This is a training as Kedar pointed out, we have an orthopedic oncologist in our unit and he always insists on a PET CT. I have issues with that, but he is very clear that we need a PET CT because sometimes there are other lesions as well. So to complete the workup, a PET CT is done as well. And then we get on with the management. And of course, after that point, everything depends on the biopsy result.
Right. But anything specific that you look into, like while planning any kind of management, anything specific, whether lesion is capsulated, whether it is spread, whether it is epidural spread?
So all of that, the study of the MRI and the CT and will give you the idea, right?
Right.
And the PET CT. PET CT will tell you whether it has got other lesions, metastasis or other lesions,
Right.
Multifocal or metastatic.
Right.
And the MRI and the CT, the CT will give you the bony border for sure. And the MRI will tell you about the soft tissue and the spread.
Right. And why do you think this is important to note? I mean, is there any specific relevance to note all these findings?
Of course, knowing, I think in the basis of any tumor management, knowing whether it is compartmentally or extra compartmental is one of the crux of your decision making.
I think
Because
this one line is the carry home for primary spinal tumor surgical management versus any management principle. This one line will decide what exactly needs to be done, whether the tumor is compartmental or extra compartmental will decide the aggression of surgical treatment. It will decide whether it will require adjuvant therapy. It will decide whether it will require a chemotherapy. It will decide whether the chances of recurrence are high or not. It will decide whether en bloc resection is possible or not. All these questions will be answered purely based on this one fact, whether the lesion has already gone extra compartmental versus intracompartmental and this can be determined by doing all the investigations that the panelists have just highlighted: CT scan, MRI scan, a PET CT scan. All these things will tell you whether the tumor is localized, capsulated, intracompartmental, and how many quadrants of the vertebrae are involved versus whether it is extracompartmental and metastasized to some other portions. Coming back to Dr. Mihir. Dr. Mihir, what are the lesions that you think in a 44-year-old male can be present? We already know Kedar is going to tell us that it's going to be a chordoma, but what are the other lesions that should run in our mind? At 44, what is the common DD?
Do you hear me, Vishal?
Yes, we can hear you, sir.
I think at the age of 44, it's little late for a GCT to present, but really, primary tumors can have an overlap between decades. So I think at this time, I would think of early plasmacytoma, a chordoma, giant cell tumor, and it's a little late for an osteosarcoma, maybe a chondrosarcoma.
Right. So remember, guys, there is an age calendar to all the tumors. It is very rare to see osteoid osteoma presenting at this age. It is very rare to see a myeloma. Though rare things may happen, but start thinking about more common things. And this is something that we all must remember, that there is an age calendar to follow. And if you follow the age calendar, your diagnosis can be coned down and you can really diagnose your investigations or direct your investigations in that particular manner. So think in these directions, like the panelists have mentioned. One, getting all the investigations, thinking in these lines, getting a biopsy done is something that is paramount. Kedar, so what did you do in this particular patient?
So we studied the MRI and we definitely got a PET CT done. So PET CT showed that this was a single lesion, and we got a CT biopsy done, which confirmed that this is indeed a chordoma. So single lesion, and a chordoma involving L5 in a young person. It was okay on all the three sides, but there was definitely almost like ballooning of the posterior cortex of the vertebral body and compression of the thecal sac over there. And you can see in axial, there was definitely involvement of the pedicle on the left side and almost going to the base of the transverse process on the left side. So basically, there was a dilemma whether what to do in this case, whether we manage it with radiation and other treatment, non-operative treatment, or do surgical management. And then if we are going to go down surgical route, then what exactly we should do? Just do a decompression or do fixation or try for marginal or a wide marginal removal of the tumor.
Yeah.
And then if we do go for surgery, then
Kedar, before you go in there, we have with us a radiologist who's into onco-radiosurgery. Let's have his opinion. Shankar, are you there with us? Can you come over here?
Yeah, Vishal, I'm very much there.
What
I'm audible.
I mean, we are seeing chordoma in a young patient. Is there something better that you can tell us? We all know that chordomas are locally, slowly aggressive tumors. They have a tendency to spread and they present quite late in the natural course because they slowly grow and progress, and they can also get converted into malignant tumors. Also, they have a very, very high chance of recurrence despite the best of surgical margins. So can you tell us if there is any other radiotherapy margins that can help us as surgeons?
So the standard treatment undoubtedly for chordoma in mobile spine or sacrum is en-bloc resection. Probably, if the size is pretty large, then probably I would consider giving neoadjuvant radiotherapy. But still, if it doesn't add any, significant morbidity, if you think the resection, en-bloc resection results in some kind of morbidity which is not acceptable, that's the time we give neoadjuvant radiotherapy. That could be hypofractionated. But just in the event you have gone ahead and done some en-bloc resection, well, there is always a debate within whether we need to give post-op radiation or not. But yes, whenever the margins are positive, that is the time we essentially need to consider for post-op radiotherapy. Standard, this is the practice which we are doing, and this is kind of evidence-based as of date.
Right. No, in fact, I'm sure all the panelists would agree with me here is that en-bloc resection is, yes, Kedar, I'll come back to you. En-bloc resection is the only surgery where you can get clear margins and reduce the recurrence rate to near acceptable limits, which is less than 1% when you do en-bloc resection. Unfortunately, on one hand, it's a good surgery. On the other hand, it's a technically demanding surgery. It has a high morbidity. And the most important part is very often it is not possible to do en-bloc because by the time patient present, either there is an epidural spread or extra compartmental spread has already happened. So Manish, what do you do to ascertain whether en-bloc resection is possible or not? Here, Kedar has already drawn some drawings there. Can you ascertain and let us know how do we ascertain whether en-bloc resection is possible or not?
Yeah, we are looking at the WVV classification, whether it is resectable or not. And especially this is L5. This is one of the most difficult locations to do an en-bloc resection because of the lordotic spine. And you have to go really deep inside. Basically, it's coming back to the margins, when you be able to take the margins out, whether there is any breach in the natural barriers like the disc, the end plate. This has already spread into the epidural space, so this may be an extended indication. Probably some people have even taken a part of dura out, the dural layer along with the margin. So you have to improvise. The traditional teaching is it has to be strictly intra-compartmental, but there have been instances where people are extending the indications and taking extra-compartmental as well.
Right. So there are various parameters, radiological and clinical, to understand if en-bloc resection is possible or not. Even if it is possible, even if it is recommended, whether it is feasible or not, whether it is going to be possible in your hands or not is something that is very important, because chordomas happen in the extremes of spine in the junctional areas where again access related morbidity is so high that in an attempt to do unblocked resection, you might have created a damage which is irreversible, like in L5 or in a C2 or a sphenoidal tumor or a occipitocervical chordomas, where they are far more common. These are both regions which are very extremely difficult, not only to excise the tumor en bloc, but also to reconstruct, because after you have excised it, creating a defect which has to be reconstructed is becoming a major challenge. And that's why, as I said, the principles of surgery involve getting a biopsy, embolization to reduce the blood loss and morbidity of the surgery, excision of the tumor in a wide margin manner. However, when you excise it, see the feasibility of it, whether unblock is possible or not. After excision, reconstruction is another challenge, and very important is adjuvants to see that you don't have recurrence in these patients. So Kedar, what did you do following these same principles for this tumor?
I will just go. But Vishal, is the radiation oncologist going to explain to us in his talk about the newer modalities of radiation?
Yes,
and
he's
all?
going to be talking to us about various tumors also, and then his way of dealing with them.
Yeah, because a lot of new literature is coming up because of this morbidity, these big procedures. And also, in spite of doing the big procedures, microsatellite lesions are left, and that's why recurrence is a problem. So there is a lot of research on newer updates in radiation. So quite keen to hear that.
Right. We are
But what?
For a whole half an hour.
Yeah. So basically, the dilemmas in this case was, as discussed, whether to give chemo or radiation in a neoadjuvant way, or whether to do surgery and what type of surgery, whether to do decompression only, fixation, and if we decide to resect the tumor, then what type of resection, intralesional, marginal, wide, or radical. Whether the surgical team has the experience to do this kind of surgery, whether the anesthesia team has the experience to assist and manage with this kind of operation, whether there's enough ICU backup in your hospital, whether you have good blood bank, bone bank to reconstruct the defect. So all these things need to be considered, and you need a good team of a general oncosurgeon and an orthopedic oncosurgeon and a spinal surgeon to deal with this kind of treatment if you're planning a big en-bloc resection. Also, the relevant anatomy, it's L5S1 junction is, as we are going to discuss, is just below the junction of the big vessels. Then there is the plexus which goes towards all the pelvic organs. So erectile impotence is a thing we need to discuss with any male patient here. And there are ureters on both the sides. So after discussing with the patient, he wanted to take the risk and proceed with surgery. So we had a marathon surgery, 14.5 hours in 2 stages in single anesthesia. Initially, we did the prone procedure and then did the supine transabdominal procedure under general anesthesia. Total 4 liters blood loss and a 3-surgeon team. The principle was to remove the tumor with cuff of normal tissue. So fortunately, we did manage to remove the whole specimen, and that is the superior aspect. That is the pedicle which was removed along with the specimen which was involved. And this is the epidural surface. The PLL is still intact. So although the ballooned cortex is there, we managed not to breach it in this case. And this was the X-ray of the specimen.
There is a lag. Yeah. We would like to see that.
Yeah. So this is the X-ray of the specimen we removed, which shows the pedicle which was involved removed along with it. And this rest of the thing we removed piecemeal. And we have a 2.5-year follow-up on this patient. As a secondary procedure, after 9 months, we did some additional bone grafting. We took his own fibula and we cut it. So we have put 2 pieces of fibula here at the back, 2 on the opposite side to help with the union, because we have used an expandable cage in the front and there is not much bone graft there. So we were worried that this might fail. And also because of the same reason, we have used a 4-rod construct to give it rigidity till the posterior bone graft unites. So he is now nearly 2.5 years post-op, and he's back to work as a police officer. So these procedures. Hello, can you hear me?
Yes, we can hear you, Kedar. Yes.
Yeah. So I am not advocating en-bloc resection for each and every of these tumors, because most of the tumors, primary tumors which reach Hinduja Hospital in the last 5 years I've seen, have already become unresectable. So they come quite late. So very few of these cases we get at a resectable stage. And we must be aware of the morbidity before jumping into en-bloc resection for these tumors. But if you get away with it without any significant morbidity, then the results can be life-changing, because this patient otherwise was definitely going to die in a few months' time as the tumor progressed. So that was just one case. I have one more case. If time permits, then
Yes.
we can discuss
Kedar,
that.
we'll come back to you on this. I think the message has gone very, very loud and clear. There are multiple messages that have come across from here. A young patient with a primary lesion in spine with mechanical symptoms is the commonest presentation of these slow-growing malignant primary tumors in spine. Very rarely would we see neurology as the presenting symptom in these patients. These are the patients where preventing recurrence is as important as giving them symptom relief, and giving symptom relief is
I think Vishal has only gone, right? I can see all of you all moving. Yeah, I think Vishal only has gone. I thought my thing had gone.
So Dalvi sir, can we take up your case? He can come back and then give a summary statement regarding the first one.
Okay. You'll have to tell me whether you can see it, because I can't make out. Can you see it, Priya?
Yes, can
We
see
can
this.
hear you.
Okay, fine. So 39-year-old female, insidious onset, low back. It's the history is very much similar, in fact, to Kedar's case. That's why I requested it to be pushed up slightly. Similar middle-aged female, and radiation to the right lower limb, and a night pain. Tenderness, back spasm. This patient had a list as well, and the neurology was normal. As you can see, this patient had a list as well, and even on the plain X-ray, you can very clearly see that there is a lesion and a lytic lesion. I don't think we need to do a quiz of the panel. I think it's pretty clear that there is a lytic lesion there. We've already gone through what is the differential diagnosis and all of that. And anyway, this talk is on tumors. So this is the MRI. And, if I can ask someone from the panel to say what they think. I mean, Priyank, if you can lead the discussion, if you want to ask since Vishal's, he sent me a side message. He has a net problem. He'll come on 5 minutes.
Yeah. So this MRI is typically showing a central body lesion at L4 with the posterior cortex, which is ballooning. There's a homogeneous appearance of the tumor, and I think it has technically it's not it's breached the posterior margin, so it's encroaching on the epidural space. So that's what I can see in this scan. Just overall looking, it does not look like a very hemorrhagic tumor. It looks more like a soft tissue tumor. Can think in lines of GCT, chordoma, etc. Hello.
Yeah. Okay. So I think that is one thing. Now the only thing is that I'm not sure what my next slide is. So I'm just going to go to the next slide for a second. Yeah, there you go. So that is the CT scan. And as was pointed out, there is no bone actually. If you can see, there is no bone. And even the upper end plate seems to be sort of affected. It's just a shell.
Yes.
So now what are the concerns here? Like what are the various concerns here? I think if Kedar is there or Mihir. Kedar, I think I see you. Kedar?
Yes, surely there is some tumor involving that vertebral body, and there is a fracture of the end plate. So the concern is it can collapse further, she can get neurodeficit. And obviously we need a biopsy and workup to find out whether this is a solitary lesion and what is the pathology, histopath picture over here. That will decide further management. And because there is no neurodeficit, we still have time with us to plan properly.
So would you think of doing a surgery quickly here, or like you said that we have time, we want to do a biopsy?
Yeah, as far as I remember in your history slide, she has radicular pain, but there is no neurodeficit. So we
There is
can
no
put her on bed rest. We can get, I think definitely if given an option, biopsy is always a good thing. We know what we are dealing
Are you
with.
not worried that this will acutely collapse and cause like a serious problem?
If we keep her on bed rest, it will not.
I know, but Kedar, this is the standard thing which we ask even first posters in bed rest. How much does the on the vertebra? Every time you do even an SLR or you twist, you get the same amount of compression on the disc or on the
But
vertebral body.
This case is different to a case with bladder bowel involvement in the last 12 hours.
Right. Yeah, because with the list and everything, one is very worried. So anyway, biopsy, everyone is for biopsy, like Mihir and all, everyone for biopsies?
Yes.
Yeah.
Okay. Any guesses? I mean, the next slide is the biopsy slide. So any guesses?
It has a lot of septates inside.
What is the age, Dr. Samir?
Manish, if you know this case, you are not allowed to talk, right? Because this case has come in follow-up when you were with us. So you are not allowed to talk. Vishal, yeah.
Sir, what is the age of the patient? Age in neurology?
39.
Sorry,
39.
I just
39-year-old female.
Yeah, so I think GCT surely comes into my mind. Yeah, GCT surely runs into my mind. And if the neurology is not very compelling to just rush in, I think surely biopsy. And biopsy from the margin.
Yeah, no neurological deficit. So it is a giant cell tumor. And now this is everything with you, the X-ray, the CT, and the MRI, everything is together. So now let's hear each one, like a few of you tell me the treatment plan, like Vishal, Kedar, Mihir, everyone except Manish.
So yes, Priyank, please. Priyank, let me start with you.
Yeah. So this patient technically has just got no neurology, and the biopsy is proven to be a giant cell tumor. Here, I would like, if the patient is intelligent and can counseling in terms of the dangers of conservative treatment, not typically conservative, I would like to wait for at least 3 months, load the patient up on denosumab, because it's known that if we are able to give neoadjuvant treatment with denosumab, it really helps with the surgery, especially the margins and everything. Probably they shrink down a little bit. There's a little bit of calcification. Surgery becomes better and spillage becomes less. So that I would try in this patient before, of course, eventually planning a surgery for them.
Kedar, how about let us hear about Dr. Shankar. What is your take on patients with GCT with no neurology, only mechanical? Is there a role of primary radiotherapy in these patients? Because remember, once you give committed, patient will not undergo surgery for coming 6 months. Given that situation that after radiotherapy, surgery done within 6 months.
So, am I audible, Vishal?
Yes, yes, very well.
Yeah, so primary treatment is not really advocated. Only in recurrent setting, that's the time we usually advise. And recurrence, the shorter it is, the more, the need to give some adjuvant treatment, salvage treatment is a priority on board. But primary radiation therapy for GCT is not really advocated in the first instance. In a navigate setting, it is not advocated.
Right, understood. So
I mean, there used to be a thing for actual GCTs and those GCTs which are not surgically amenable. There used to be a previous mega voltage GCT mega voltage radiation.
Yeah, so that's what, but again, the intent is essentially not curative at that time. The biggest reason, surgeon is one of the important prognostic factor. The operating surgeon is an important prognostic factor, regardless in the brain or spine or any other area. Now, getting clear margins and negative margins by keeping the morbidity as low as possible is very important in getting better outcomes in the treatment. Having said that, if you have a lesion which is not really amenable for surgery, situated in a site which is surgically inaccessible, or the patient is going through some morbidities, medical morbidities, that's a situation we can use radiation as primary setting, but again, it is not with a curative intent. The intent obviously will not be curative in that situation. The chances that it is going to recur is very high, but in the last 20 years of my practice, I mean, I have not really treated any of my patients GCT primarily with radiation therapy, but we have treated 3 patients in a second recurrence and 1 patient in third recurrence. That's
So
how.
I think I would like to make a statement here is that in the last 10 years, how we have started seeing tumors has completely changed. Not only because the reason that the radiotherapy has advanced from one end to the other end, now there is a whole spectrum open from radiotherapy point of view. Now there are drugs that are available for primary tumors, like Priyank just mentioned the role of denosumab here. The role of sequential embolization has been better understood now in these tumors which are vascular in nature, which are driven by the of nature. Like in hemangiomas also, they treatment and radiological treatment helped quite a lot. And there is phenomenal advancement in both the chemotherapy part of it, the radiotherapy part of it, and that's why the morbidity of the surgeries have come down. On the other hand, when it comes to surgery, the way we used to be fearful about the approaches related to surgery, now I think the morbidity of most of these surgeries, for C2 now there are these high retropharyngeal approaches, submandibular approaches, which are really, really very well understood, and that is why the morbidity of these approaches have also come down. And in lumbar spine also, we just saw Kedar showing one case where you can do front and back job with these approaches. Again, the morbidity of these approaches have also come down very significantly. And that is why the understanding of these tumors have come down quite significantly. For me, in this case, if the vascularity of the tumor is quite high, I think embolization one, I'm not a very good unblock surgeon, so I would surely want to stabilize this patient because it is more than 50% involved. There is a pedicle, so I really worry that this may develop a pathological collapse, making it a difficult tumor to resect at a later date. So as of now, MIS stabilization, tumab, and follow up this patient. If the tumor dries off, nothing like it. If it doesn't, from the front and excise it completely. Dr. Sam, that is my plan for
anyone for a block for this?
Unblock. I think this is a tumor
No.
possible because for unblock to be possible, there have to be at least 3 and ideally 4 quadrants vacant. If there are less than 3 quadrants available for resection, it is not a tumor where unblock is possible. You'll surely have a spillage, and a small spillage versus a good decompression in a piecemeal manner is better rather than having a stage unblock.
I think Dr. Samir, both the pedicles are involved. So technically also it is going to be difficult. And the other thing is nowadays with GCT, it is not as aggressively growing tumor to jump in and take it out fully. We have denosumab, we have curettage, we have bone grafting, we have cementing, and we have stabilization. So I don't think, the morbidity with an en bloc, although things go well if you have a big team and all that, but still, why would you want to do it? If it was me, maybe I would say not an en bloc for this.
Okay, so can I go ahead now in the interest of time?
Yes, please, Dr. Samir.
Yeah. So what we did for this is we saw some papers, and although now this has already come, but this case was 2013 or something, at which time the early literature was coming on adjuvant treatment. So what we did was multiple embolization, zoledronic acid and denosumab. This was at a stage when denosumab was not available in India. So this patient had to get it from Singapore. So this patient got from Singapore, and we used to give, again, Manish was, and the chemotherapist was leading this, but I think every 3 weeks or something, we were giving denosumab, and we did multiple embolizations for this patient. The only thing what we had to do, 2012 ka patient, the only thing is we were very concerned about the collapse. We didn't want this patient collapsing suddenly. So before starting all of this, I just did a quick percutaneous stabilization. I mean, now you all know this. I don't need to show you all X-rays and photos. But we basically did a percutaneous.
You look young.
Sorry?
You look very young in the photo.
Yeah. 2012. So we did the percutaneous stabilization, and then we went ahead and we did, there it is. We did monthly embolization plus zoledronic acid, 4 sessions. And in fact, after the first embolization, that pain relief went. She had severe leg pain, actually.
there was one thought that we should also do a decompression because she had very severe leg pain. She had the list, in case you remember.
Yes.
We did that, and we did all of this, as well as we started giving denosumab, and this is the picture now. So over till Feb 2013, from October, you can see that in the there is an increased density and the margins are becoming better, as you can see.
Yes.
And
Yes.
from Feb, we started on injection denosumab. So as you can see, we did this 1, 8, 15, then monthly injections, and patient followed up every 3 months with a limited CT. So total 17 injections, and this was in the time when she used to get it from Singapore at the pop of 75,000 per injection. So I think surgery may have been cheaper for her, but anyway, they could afford it. So we did that over 15 months, and these were the follow-up CTs. As you can see from the beginning, from the first dose, here you can see the margin forming. You can see all of this calcifying, and now you can see there's a full margin here, and all of this has got calcified. Can you see this?
Yes.
And all of this margin has got now.
Yes. Can I please?
So this is what we did, and the MRI as well improved a lot. As you can see that whatever was bulging and all came back. There was no. I mean, the compression went away immediately. Like the pain went away immediately, and she was stabilized. So we did that, and then this was the situation. The X-ray in May 2014, 15 months of denosumab. Everything looks stable. This now it became like really just a contained or like a intra-compartmental disease. And at this stage, we went ahead with extended curettage. So we didn't do a vertebrectomy. We actually treated it like a GCT, how you used to treat a GCT of the lower end of the radius. And we went in and did an extended curettage and packed it with cement. So the extended curettage included curettage as well as use of the argon plasma. We used this argon plasma electrocautery to cauterize the edges of the thing. And then we packed it. We sent multiple biopsies from various things, and there was absolutely no giant cells. There's fibrosis and new bone formation, and this shows a good response to denosumab. But we still give 3 more doses of denosumab post-op, and this was the 6-month follow-up. As you can see, that cement which is there. So whatever you see in front of the vertebra, also don't worry about it because this was packed under vision. It was not a vertebroplasty. And this is 2014, and this is the 15-month follow-up 2015. And but she's still following up. So now it's 2020. It's 5 years from the end. So 2012 to 2020, she's doing pretty well so far.
Samir, for the benefit of the viewers, I wanted to ask you, when we give this zoledronic and denosumab, a lot of these Indian females are vitamin D deficient. So do you check for and top them up and ensure that they maintain a normal vitamin D level while they are receiving denosumab and or zoledronic?
So I'll give you the answer which I give all my patients whenever they ask me such complicated questions. I tell them I am a carpenter. Mujhe wo khila bila sab to, oh, so I'm sorry, my video wasn't on. I'm so sorry. I changed my position. Sorry. Hi guys. No, because I couldn't make out. So I tell them that I am a carpenter और वो screw boo मुझे सब डालना आता है, ये बाकी मुझे नहीं आता है, वो असली डॉक्टर को पूछो. So we refer them obviously to the oncologists or somebody else to field these answers.
Yeah, but
so yes,
one more question. Now,
Manish is remembering his days. Manish is remembering his 2 years in my clinics, and he's going to one day write a book about what I do in my clinics, I think.
I think we need to understand that denosumab and zoledronic acid both result in hypocalcemia, and that is why you cannot use this in situations where patient is hypocalcemic, patient is on any kind of Lasix or any kind of such agents which lead to hypocalcemia. Patients with hypoparathyroidism, you cannot use these things, and patients with neurology and pathological fractures, you should not use. This regimen is meant for contained GCTs with no neurodeficit. It really works wonders. It has mentioned literature. There is enough paperwork on this now.
So however, at the time when, let me just tell you, at the time when we did this case, there were only 2 case reports in literature. There were 2 cases of sacral GCTs which were treated by this. And I'm not sure whether
this forward, that is a wonderful therapy. You started back, but now there is there now, and there is a very clear-cut guideline that you can do the contained symptomatic compartmentalized GCTs with no neurodeficit and no pathological fractures in patients where hypocalcemia is taken very, very well controlled in a note of, because you will have to really load them. You did it in 2012 with zoledronic and denosumab. It is the same regime is being followed even today. However, many of these patients will land up into hypocalcemia and other issues, and that is why one should be aware that these are wonderful therapies for a select group of patients. Please don't take it as a generalization where a patient has a neurology, extra compartmental spread, or a patient with neurology or with a fracture of the vertebrae. So
but
wonderful,
yeah,
Dr.
absolutely.
Sameer, it has been
So
amazing.
the indication for this is very clear, as was well pointed out. This was taken as as a treatment for axial and inaccessible GCTs, and the point is that what actually we achieved. There was a lot of trouble and expense to the patient. I will not deny it. See, multiple embolizations, multiple admissions. All of this. The zoledronate is also given IV. So there was a lot of trouble for the patient. But at the end of it, we could get away with a posterior percutaneous surgery and an anterior cementing. So I
Very
think, overall in the larger picture, we have won, and she was pretty young. So actually, I should thank you. I remember that we had done this case, and we'll write it up now. 5 years follow up. So we'll write it up.
Right. So I'll just bring about a very similar looking case, which is a GCT in a patient where we did a little different kind of job, where this was a case where we did just give me a minute.
Vishal.
Yes, Mir sir.
The thing is that, Sameer's case is an excellent eye-opener. In grade 1, grade 2, grade 3 tumors, where the role of an R-block resection is optimal, we have found out that denosumab is an excellent treatment for GCT.
Exactly.
Grade 4, grade 5, grade 6, there is a controversy between R-block and debulking. And then comes the role of R-block resections.
No, so the fortunate part is that it has worked wonderful in GCT. However, unfortunately, it has gone into disrepute purely because of its extended use in ABC, in chordomas and other tumors which are not amenable, not recommended neither for denosumab nor for zoledronic acid. And unfortunately, many surgeons in our country have started using denosumab and zoledronic acid for extra compartmental tumors or patients where paralysis is also there. So it is not a primary mode of treatment in that group of patients is what I want to bring forward. And this is one very similar case where we did this case in 2012.
Vishal.
Yes, Kedar.
Yeah, just a question to the panelists, because I am not very clear with the answer. Now, when you manage this GCT with denosumab and zoledronic acid, when do we stop it, or do we keep it lifelong on some maintenance dose?
Dr. Sameer, would you like to take that question? The duration of denosumab and zoledronic acid, how long do you give this?
So we have been following this up, the denosumab. See, because we did the multiple biopsies and there was no tumor in that, and we did the follow-up CTs and MRIs as well, and there was no tumor. Therefore, we could stop it at that stage. As I said, we gave 3 doses after the surgery as well.
So
but I don't think there is any fixed. I'm not aware of any fixed protocol for this. I think maybe we can ask the oncologist, but nobody's aware because this treatment is still anecdotal. Yeah. Nobody has a huge series for this.
Okay.
There is none. In fact, the way Priyank, please Priyank.
Just like to add here. Here we have done the extended curettage with argon laser, extended curettage argon laser, as well as the cement. So that should be a definitive treatment. And because the biopsy showed a few stomachs, we decided to add some of the another 3 doses of denosumab. In a routine appendicular GCTs, we usually stop at the cementing and extended curettage, and we look for recurrence if any at follow-up. That was definitive.
So for recurrence, do you do a PET CT and MRI both, and at what frequency? For GCT recurrence, how do we know?
Kedar, I'll tell you, denosumab, it works like an anti-resorptive which works on giant cells. It is better anti-resorptive. It works on giant cells than any other anti-resorptive. Zoledronic acid is also anti-resorptive, but it prevents bone resorption without working on giant cells, and that is why denosumab is useful better than any other anti-resorptive. Number one. Number two, it is only one drug which can be given lifelong, and that is why even in osteoporosis it is kept like a maintenance therapy for lifelong, given at 6 monthly interval. For tumors like Dr. Sameer mentioned, There is no such protocol for how long you have to give, but you have to keep following, and sometimes you may have to give it really lifelong. Just another case scenario of GCT, a 27 female with a pathological fracture was on AKT, against diagnosed as tuberculosis, was given TB medication. And this is very similar to Dr. Samir, what he mentioned. However, in this patient, if you see, there is already extra compartmental spread which gone into the anterior and the epidural area. Patient had severe radiating pain in the flank area with a CT guided biopsy. Again, making sure that multiple chunks are taken with a thick core needle. If you see that the size of the needle, this was done under guidance of a surgeon. And then multiple chunks from the peripheral lining of the tumor was taken, came out GCT, and the principles of the surgery were kept into. And these GCTs are extremely vascular. So mind you, they are
I agree with
very vascular.
what Surya is saying here.
The morbidity after
and trying to restore height is of no
and then surgery.
extra advantage.
Remember, this is a pathological fracture had happened, and that is
sort
one
of
block resection.
settled
But what you can achieve is clear margins, compress the patient, stabilize it, and reconstruct and to prevent recurrence. Sometimes you have to give so what we did was embolization. We then did a stage, first anterior and followed by a posterior, and now we have a 7-year follow-up of this patient. There is no recurrence. That's the 5-year follow-up X-ray of the patient showing complete fusion. And this is what we did. And this is so. This is one.
I don't see a particular cavity.
And we saw the other way of dealing with DCT. However, more often than not, DCT unblock is not possible. Like in this particular case scenario, the vertebral artery was encased.
In the center,
we have dealt
on the extreme,
and now there is 5-year follow-up this patient again. Anterior and posterior job done. Again, in this radiotherapy, even but we never had phototherapy at that time. Seven years, and that is why prolonged follow-up is what is recommended in all these patients. So, moving on from GCT now, we heard a good carry-home message about maintaining and seeing which patients can be done. Dr. Mihir, your turn now. Your case would want to come in now. The messages from this case are plenty. Whether to do or not is a decision based.
I can't hear you guys. Can you hear me?
Of the tumor. Yes, we can hear you. We are waiting to be shared.
Hello.
Yes, we can hear you, Mihir.
Block resection on one hand is a good surgery. However, in GCT, isn't a big surgery. If surgery is required, try to attain clear margins, and adjuvant therapy, like Dr. Shankar mentioned, is sometimes recommended when there is a high spillage to prevent recurrence. Dr. Mihir, are you ready with the case? Dr. Mihir?
I can't hear you. Can you hear me?
Yes, we can hear you, sir. We can hear you.
Reception is very poor. I lost you for about 10 minutes in between.
So now, can you hear us, or we will move ahead with Priyank's case?
Yeah, I think so, because the video is very slow.
Load your case. Priyank, please come up with your case.
I'll do that.
And then Mihir, be ready. We will be coming back to your case, and then we move on to Shankar's talk.
Okay.
Perfect. So this was a 11-year-old girl with primarily complaining of neck pain for the past 6 weeks, slowly progressing. And over the past 2 weeks, the patient really has got significant spasm. Her range of motion is restricted. However, she doesn't have any major radiculopathy or myelopathy. She came with an MRI, and this is what I had seen in the MRI.
C3.
So so in this area, if you see, there's something in the posterior elements of C3 vertebrae. Those other sections.
Manish, any idea what is happening? Manish, can you please, for the sake of all delegates, please describe what else can you see and what comes in your mind? 11-year-old female with neck pain.
You look at the left bottom image. It is showing intense uptake in the posterior elements. So there's probably the lateral mass and probably partly extending into the spinous process as well. And there is significant ballooning. So obviously we like to see the axial images at that level. A young girl, posterior elements, and intense signal. So yeah, the differentials are already running in my mind, probably in osteoma or something like that.
So that's the
Here
actual
is one
images.
image. So if you see the on the second row, the uh, rightmost axial image, there's a large soft tissue component and coming on from the lateral mass. It's just abutting the
So yeah.
vertebral arteries as well, left vertebral artery.
So
Any
that's the
more
lesion
images?
Dr.
Yeah.
Manish is, yeah, that's the lesion Dr. Manish is talking about. And that's the post-contrast image.
Yeah.
So that's the area that we are discussing.
Right. So same. See, there's a point of note here is there's a very intense signal around the lesion. So my suspicion of osteoblastoma will be very high, but I'd like to see a CT scan there.
Okay. So that's the CT scan of the patient. If you see,
while we see this discussion happening, we all also understand what all things have been noted by the panelists, guys. Remember that 11-year-old child with only neck pain, please don't just throw them away. They're in kids. Remember the age calendar. In kids, any symptom is a very significant symptom. Kids complaining of significant neck pain, the chances of them having a hidden infection or a tumor is very, very high. They do not have degenerative neck pain. They do not have spondylogenic pain. And that is why kids less than 15 years coming to you with neck pain, back pain, thoracic pain, suspect they may be running through some tumors. And the commonest tumors in kids can be as simple as eosinophilic granuloma when they are less than 5 years. From 5 to 15, it can be osteoid osteoma, a ABC, a lymphoma, or a histiocytosis, or for that matter, a osteoblastoma. And all this is running. And when you see tumors in cervical spine, like Dr. Manish was just reading this, he was seeing the extent of tumor in the soft tissue extension and also its abutment to the vertebral artery and critical structures like spinal cord have to be studied in great detail on all these images to plan the surgical management that you're planning. So Manish, you have a CT scan now. Any change in your words? An idea? A ballooning lesion, lateral mass, left side, C3.
Yeah, it's a ballooning lesion. So it's not clearly an osteoid osteoma. There's not much of sclerosis. Some variants of osteoblastomas may have such a picture, but probably I'm also looking at ABCs in this patient.
So, Dr. Mihir, what all other things would you want to investigate? And what is the differential running in your mind? 11-year-old female, only neck pain, mild torticollis, C3 lateral mass, ballooning lesion.
In this particular situation, you can see a faint rim of reactive bone around the lesion. So it's a slow growing lesion. It's not a very rapidly progressive lesion. It's a uniform lesion with no stippled calcifications or sort of periosteal reaction around it. So probably all those childhood problems of Ewing sarcoma and all are ruled out. It is probably an osteoblastoma, which is a more aggressive variety of an osteoid osteoma, or it can be, it can be otherwise an ABC, but too young to have an ABC either. So let's have a biopsy in this finally.
Right. Dr. Dalvi, how would you approach this patient? This lesion is surely looking for a surgery. It's a benign capsulated bone forming tumor, can be a ABC, can be osteoblastoma, or even a soft tissue tumor there. Dr. Dalvi, how would you deal with this patient? Biopsy or do a definitive excision and do a biopsy then? Is Dr. Dalvi there with us?
Can I, before Samir comes up, can I add one more thing?
Please.
On the MRI, there was a very hyper intense zone around extremely hyper intense zone around this lesion. Now, the lesions which produce such kind of soft tissue reactions and are circumscribed, slow growing progressive lesions are usually pointing towards an osteoid osteoma kind of a lesion. It does not point towards an ABC. It does not induce so much of inflammation in the soft tissues.
Right. So, right. Very important. I think bone formation lot of inflammation is a bone forming tumor, and that is why it is very important to understand it can be osteoma. However, a ballooning lesion can easily be a secondary ABC in a primary tumor of any nature. Priyank,
Yeah.
so what did you do?
So I want to ask, I want to ask, would anyone do any other investigations like CT scans of the chest, abdomen, or PET CT or anything to categorize, or go for the biopsy first?
Biopsy first.
Biopsy first, yeah.
Perfect. So this is one thing that I wanted to point out. Like in a radiological setting, if it is overtly looking like a benign lesion or something that is locally aggressive, it's ideal that you do a biopsy first rather than jumping for a PET scan, because again, you have to think about the radiation and all involved in those tests. So here, as suggested, we went ahead with a biopsy. It was a CT guided wide core biopsy, and the results were pointing towards aneurysmal bone cyst. They had some query regarding osteoblastoma, especially because when, like what Dr. Mir Bapat presented, the periosteal reaction in the contrast image was pointing towards more of a locally aggressive lesion than a ABC. So this is where we were, where the pathologist has said it looks like ABC, but you still need to rule out osteoblastoma after a biopsy. So here, what would be the plan of how to proceed?
So I think the options of treating ABC, we all must understand that aneurysmal bone cyst are of two different types. Primary ABC, where there is expanding ballooning lesion, doesn't lead to formation of bone around. There is no edema on MRI. Whereas there are secondary ABC, which is far more common. It is a collection of blood and blood vessels into an expanding tumor. So this is like a secondary ABC happening in a osteoblastoma. And the options of treating these are not many. In a primary ABC, sequential embolization does work. Even injection into the ABC, which is kind of simple bone cyst, does work. However, when there is a proximity of cord, you should not inject alcohol there. And this patient surely with the osteoblastoma kind of feature requires excision, a complete excision with a wide margin if possible is the treatment of choice in this particular situation. And since you are going to be taking down the lateral mass completely, a stabilization, like we know the principles: biopsy, embolize if it is vascular. It is not vascular, so don't embolize. Decompress. Here there is no neurologist, so don't decompress. Excise the tumor, reconstruct the tumor, and long follow-up to see if there is any recurrence happening. So for me, excision of lateral mass fixation above, below on both sides, a lot of bone graft there, and follow-up.
Okay, so I'll tell you what we did in this patient. Once we had the histopath report, we discussed with the tumor board, and eventually the histopath report was conclusive towards ABC with a radiological picture giving the DD of osteoblastoma. We had a discussion with the parents, and we basically did not do anything. We just waited and watched, because one of the known treatment of aneurysmal bone cyst is if you are able to puncture directly and the fluid escapes. A lot of times you see that calcification happening, and this is basically what happened in this patient. Post biopsy, we just waited regularly, 3 monthly. We were following up with the patient, getting a CT scan, and right now she is at 1.5 years with calcification seen. That if you see in the 3D CT also, the walls have completely formed, and that's the clinical result. So since we waited, we were able to avoid a significantly large surgery in a small girl.
Right. So basically, Priyank, you're trying to emphasize that you waited and did a very close supervised neglect, right?
Yes, exactly.
So I think the word here is wait and watch with a very close supervised neglect. Wait and watch is one option. So this is one of a case where it worked, and you were lucky that it was a primary ABC. And there are anecdotal case reports which are present there. However, the definitive treatment, as we just mentioned, we discussed that if it's a osteoblastoma, we must think of excising these patients. Okay, thank you, Priyank. We will move on to Mihir here. And any opinion from any panelist? Manish, any insights into this case?
One quick question to Priyank. Fantastic case. Did you consider a bone scan?
Vishal,
Because
can I
MRI wise, it pointed towards like an osteoid
Yes, Shankar, we'll come back to you.
But
Priyank, you want to take off the slides,
bone
please.
scan?
Take off the slides, Priyank.
Yeah, I'll do that.
Yes, and Kedar's question, please.
Yeah, did you
No, I got your question. Here in this patient, I did not think about doing a bone scan because after talking to the pathologist, I was sure that it is a ABC. Osteoblastoma, we were just figuring because of the periosteal reaction. And every time when the
Yeah.
patient was coming for a follow-up, we did a repeat MRI scan to see what's happening with the periosteal reaction. And overall, we realized that the soft tissue is also reducing. And hence then we were sure that it's ABC. And then we had a quick, a close follow-up, and that's how the results came out.
Okay.
What was the impression of the tumor board here? Such kind of periosteal reactions with ABCs alone are common, or it's a rare occurrence?
No, it's a very rare occurrence, and although there's no scientific evidence to this, but the family does give a history that before they got that MRI done, there was some intense manipulation done by some quack, and maybe that is what caused the periosteal reaction when they did the MRI. That's what my suspect is.
Right. Shankar, your question on that, your comment and question, please.
So the question is, no, usually ABC, there is role for radiation as well, but more so in a recurrent setting, post curettage or embolization failures. Usually that doesn't happen, but we have treated a couple of patients recurrent ABC with radiation therapy, and the results are really very good. Even with radiation parsing, just 4 weeks of treatment, that should be more than suffice. Maybe around a dose of around 30 to 40 gray should be more than suffice to achieve a very good local control of the disease, and there will be a good response as well. One of the patient had a very fast aggression of the pain as well. The patient presented with radicular pain, which has been radiating to one of the limbs. Post radiation, the patient had relief probably in 2 weeks down the line. The effect is also very fast because we use hypofractionated doses, and that precisely acts by creating some vascular apoptosis. So definitely it is one modality which can be explored, but only in this specific scenario.
Yeah, thank you, Shankar. I think few messages from Priyank's case I will just like to highlight, and a very classic case that Priyank mentioned, very similar to that. Tumors in kids, they usually present with very, very subtle signs and symptoms. Like in this patient with a normal looking X-ray, only neck pain, restricted ROM, patient was sent home on only NSAIDs, only to come back after a year and later when we found that there was some sclerosis, and this sclerosis kept on increasing when patient came back to us ultimately after 3 years of primary representation, and when we did a bone scan to see that the tumor has gone beyond the things, and then this is the kind of tumor that was there. Remember, this was the same patient which went to a physician or an orthopedician way back 3 years ago and was neglected. And it is a high index of suspicion, which will allow you to catch these tumors pretty early in the case of the evolution. And these tumors can be prevented to be seen at this stage. This is the case of osteoblastoma. Again, in this patient, we did a biopsy. Biopsy turned out negative. This patient had no neurology. If you see, the tumor was abetting the vertebral artery. So in these kind of lesions, which are more than 2 centimeters, you need to do a complete excision of the tumor. That's what we did, and reconstruction. And then later followed by long follow-up. And this patient now has 7 years follow-up, and there is no recurrence happening there. However, osteoblastomas are known to recur, and we are continuing follow-up in these patients. Very similar kind of tumors can happen in young individuals like this, in a patient where patient presented with only neck pain early in a 22, sorry, it's a 12, it's a 22-year-old lady where we did a tubular excision of the tumor from the lamina. Another patient where we used a navigation guided excision of the osteoid osteoma from the C1 lateral mass in a female. So this is another patient where patient presented only with neck pain. So very, very subtle signs of mechanical symptoms. This is a patient who came to us with only neck pain and very mild restriction of neck movement, where we did a detailed CT scan to come to a diagnosis that there is osteoid osteoma of the C1 lateral mass, and this was excised with the help of navigation guided drill without actually, this was bang behind the vertebral artery, so we went in below the C1 lateral mass there. Another patient, this is a case where my colleague Dr. Arvind Kulkarni did it under navigation, a osteoid osteoma of the end plate of the C5, where he did a navigation guided burring, and again presenting only with neck pain. And these tumors can actually present with very subtle signs, and very high index of suspicion is what is required to come to a conclusion in these benign tumors. Dr. Mihir, over to you, your case presentation now, and then we move on to Shankar's talk on radiotherapy in tumors. Dr. Mihir, your case is ready?
Can you see my screen?
We can.
Okay. Just give me a minute. Yeah. Okay. So this is a 39-year-old male presenting with progressive neck pain and spasms, but able to work for the last 4 months. The range of movements are terminally painful, really no neck signs. The neurology is normal and there are no medical comorbidities. This is his picture. Yeah, so there's a huge, you see that the spine is literally looking normal, but there's a huge mass which is in the paraspinal soft tissue filling up and is eroding, infiltrating into the laminae. What would be your impression in a 39-year-old about this particular pathology?
So I think like we just discussed that tumors, primary tumors in and around spine may be either from bone, cortical or bone marrow versus from the muscle and the ligamentous areas. Like this looks like to be either a myxoma or a myxosarcoma, or it can be pure sarcoma. So to me, it looks like some malignant tumor. Why? Because there is no encapsulation, there is heterogeneous arrangement, there is necrosis seen there, there is edema seen there, and these dotted appearances in within the tumor mass, they raise a suspicion that it's a aggressively growing tumor with no neurology, with only neck pain. Uh, I'm worried that this can be a malignant tumor rather than a benign tumor. It's a quite aggressive malignant tumor.
So we did a CT guided biopsy. It came out to be a mesenchymal chondrosarcoma. Okay, so so we had our onco team. We had a pre-operative embolization of this tumor. Now the question was, there was a lamina involvement of the C3-4 with an overlapping tumor from behind, which was extending from C2 to almost D1.
I think the primary problem in these soft tissue tumors is exposure. No matter how much you try to have, because they have no capsules, the problem with them is because of lack of capsule, there is no definitive demarcation of the plane of exposure, and you invariably land up inside the tumor. So it's extremely impossible for a soft tissue tumor of that magnitude with a malignant nature of heterogeneity that you will be able to get a completely normal core tissue around the tumor on all the fold margins. It is going to be extremely difficult. Unless we do that, the chances of these tumors recurring back again and again is very, very high.
Yeah,
that's my contention.
So basically, what we had planned in this was, because of the magnitude, really getting around the tumor and exposing from the midline to go around this through a normal plane and then coming around here is going to be a problem, because you can really not retract till there. So we had the plastic surgeons with us. They created, the modified Mercedes-Benz kind of incisions, and they really dissected around into this muscle, and they got the whole plane to go around there. And really this margin is poorly defined. So that's the interface between the bone and the tumor. So here you had to go intralesional, because you can't really approach from here and try to get this out, because the whole tumor is overlapping there.
Right.
So we got the tumor intralesional out from there, and then we completed a laminectomy. Post-operatively, the patient had consulted a medical onco from Hinduja, and he was put on chemotherapy and radiotherapy. And this patient till now has completed about 2 years now. And he so far has not shown any signs of recurrence. I would like to ask the faculty, in terms of a chondrosarcoma, how much period can you really wait before you call him tumor free?
Priyank, any idea? I mean, for how long do we wait for it to call a tumor free patient? Because I think in chordoma, recurrence has been reported up to 20 years.
Yeah.
Patients were symptom free for 20 years and have recurred at that late. Priyank, your opinion, then Manish,
So-
and final word from Shankar, how to prevent recurrence.
So I think in an intralesional surgery, we can never say that the patient is tumor free. You have to always keep watching for recurrence, because as you said, you can see recurrence after 10, 20 years also. Of course, if you have got a wide margin with no tumor for 2 years, then I would say that.
Right, right.
I'd just like to add till Priyank comes back. So I'll give a different side of the story. I've been following up one patient with a sacral chondrosarcoma. Never had a biopsy. He was advised repeatedly, and he's been living with the tumor for at least 4 years. And I've been seeing him for the last 2 years. He absolutely refuses biopsy, refuses surgery. He just has pain, and he's living with the pain. I'm assuming it's a low-grade chondrosarcoma.
Recurrence, yeah, yeah.
Vishal?
Yes, yes, sir. I'll come back to you, Shankar. So in chondrosarcomas, what is your take on role of radiotherapy, and what are the primary tumors where radiotherapy really helps?
Yeah, so low-grade chondrosarcomas are considered to be relatively radioresistant kind of tumors. What we precisely do is suggest adjuvant radiotherapy only for incompletely excised high-grade conventional dedifferentiated mesenchymal chondrosarcomas. Usually the doses are given around 60 gray, and that achieves a maximal local control. Again, it depends more on the site where we are radiating and the beams which are getting used. But undoubtedly, the role of radiation comes only for incompletely excised. In this case, Dr. Meir has done complete excision, I believe. What is the status of the margin, Dr. Meir?
The majority of the tumor was in the muscle, and that was really a wide margin. We had a very good wide margin.
So there is no really role for any radiotherapy, and chemotherapy usually, whatever you see with regards to chondrosarcoma, there is no role for any adjuvant chemotherapy after complete resection. Usually the role for chemotherapy after complete resection comes only in dedifferentiated chondrosarcoma, and again that also is really controversial. So there has been some retrospective study with doxorubicin based regimens, but again, the survival benefit is really not much.
Meir, sir, Dr. Meir, back to you.
From the surgeon's perspective, the complications of your arm mask dissections have to be weighed carefully against the complications of surgery. Okay, so this is a case of a chondrosarcoma which I first treated in KEM hospital. This was 20 years back. Recurred after 5 years. We debulked because of the hardware failure, we came to know. Then we reconstructed. It recurred after 9 years. And then we again debulked. The patient landed up with a CSF leak, a pneumocoel, and a patient finally expired after 3 debulkings.
Yeah, I think it's something that, yeah. So what the summary message, Dr. Mihir, from your case, and then we move on to Dr. Shankar.
So I think particularly when it comes to malignant tumors that are primary in nature, when we talk about osteosarcomas and chondrosarcomas, these are extremely rare. They are only about 1% of the whole spinal gamut. And they often take us by surprise. Unless you have a proper biopsy, you can never diagnose their grade. And you have to have a multidisciplinary approach in these tumors. And the only treatment in sort of chemo and radio-resistant tumors is a wide margin. If you have anything less than wide margin, you are looking at a long-term follow-up for recurrences. And these may present even after 3 years and 5 years.
Right. Yeah. Thank you, Dr. Mihir. I think we'll just move on now. Can you off-share a screen?
Can I add one point to Dr. Mihir's this thing? Vishal?
Yes, please add on. Please.
Usually when we speak about sarcoma, low-grade sarcoma, it is the 5-year survival that we typically kind of speak. But like the question was very specific, what is the duration that we need to say, whether it is control or not? So 5 years is a reasonably evidence-based deadline we can have. But having said that, as Vishal alluded to, You can see sometimes recurrences after 10, 15 years also. But again, those are anecdotal. By and large, we are 5 years, whatever you see, that is any of the published series you see, it is 5 years survival that is usually tracked upon.
Right. Dr. Shankar, thank you so much. Dr. Mihir, it has been wonderful session so far. And we as surgeons have been dominating the whole scene here so far. Unfortunately, we forgot about the 4 most common tumors where surgery is not definitive, not complete, and not foolproof. These 4 common tumors include 1. GCT, 2. Plasmacytomas, 3. Patients with chordomas and patients where unblock resection is not possible. Like in this patient with GCT, unblock resection was not possible. Wide margin is not possible because the tumor was touching the aorta, and that is why piecemeal resection was done. In this patient, again, a GCT, again, unblock was not possible. Wide margin is not possible. Again, piecemeal decompression reconstruction is done, where the role of radiotherapy comes into place. Another kind of lesion, hemangiomas, like in this particular patient, again, a very aggressive kind of lesion. Again, you cannot do an unblock resection, not only because the lesion is very aggressive, embolization is not helping patient with neurology, but also if you see the CT scan here, there are multiple dots here. This is like a Winn-Lindew Renoy syndrome where multiple hemangiomas are present, and that is why this one case we did only posterior decompression and reconstruction after embolization, again giving us a need of radiotherapy coming into picture. Malignant tumors like these, where L3 lesion you cannot do, a patient with plasmacytoma and patients with chordoma. I'll not go into the details of that. Like this patient, where again a need of radiotherapy is doubtful. There is always a question whether radiotherapy should be done in these patients with plasmacytoma or not. And then last but not the least, patients with chordomas, like here C2, where the fracture is already spilled across, and you can only at the max do a piecemeal reconstruction, piecemeal resection and reconstruction. That was done in this particular case scenario after a biopsy. And what we did was this. We did an anterior and posterior reconstruction of the C2 from sphenoid to C3 and posterior reconstruction with grafting done there. However, there is growing evidence now that there is a need of adjuvant therapy in all these aggressive tumors, be it GCT, be it plasmacytomas, or be it chordomas. Even when you are doing an unblock resection, a complete spill-proof surgery cannot be really said to be working, and that is why the role of stereotactic radiotherapy or high-dose proton-based radiotherapy in spinal tumors has been taking a precedence here. And this is what spinal radiosurgery is all about. The whole world of spinal tumor management has been changing, and I'm sure it will evolve from here, making life easy for surgeons and better for patients from here. And who other than Dr. Shankar, who's the director of stereotactic radiosurgery at HCG Oncosurgery Centers in Bombay and also at various other centers in country. Dr. Shankar, welcome, and please enlighten us about the role of SBRT in benign and malignant tumors of spine. We welcome you all on behalf of Bombay Spine Society.
Thanks much, Vishal. Really appreciate the time the faculty of BSS have spared in this evening. So the next 20 odd minutes, what we'll be focusing is the role of stereotactic radiosurgery with spinal lesions. So what slides are not scrolling. Yeah. So what I'll be alluding in the next 20 odd minutes is the work which we have been doing over the last decade or so, and majority of the work was in metastasis. We have done around 370 cases and benign around 70 cases, and we have around 18 publications in this peer-reviewed journal, and it was more on CyberKnife and X-Knife equally on both the technologies. As majority of the audience here are surgeons, I thought it would make some sense flying you through the basics of what radiation is all about. In radiation, typically we use electromagnetic spectrum. Now this is very important. Electromagnetic spectrum encompasses from long radio waves, which have a larger wavelength, to the gamma rays, which have a smaller wavelength. What we use in radiation is this X-rays and gamma rays, which have a high frequency with less wavelength. So this particular range of electromagnetic spectrum is essentially ionizing radiation. So when you say ionizing, it is capable of displacing the electron from the lower electron shell to a higher electron shell. So the take-home message here is essentially using ionizing electromagnetic radiation is what we do in our clinic. So what happens when an ionizing radiation hits it? You have complex physics interactions as fast as what you see here. I don't even know whatever decimal it comes. Chemistry interactions happen right in there, and observable biology responses can happen varying from seconds, minutes, hours, days, and months and years. So it's very important. We need to understand how this takes so much of time. So when the radiation kind of hits the cell, it causes double-stranded DNA breaks directly, or what it does is this radiation goes and interacts with the water, which you see in the adjacent area inside the cell, and that results in the production of hydroxyl ions and hydrogen ions, and they in turn go and cause the damage. So essentially, if you see, this causes double-stranded damage. Now, what is important in radiation is to increase the therapeutic ratio. How do you increase the therapeutic ratio? By increasing the tumor control, while at the same point of time decreasing the normal tissue complication rate. Now, this particular context would be more helpful for us in increasing the local control rate as well as the quality of life, and thereby decreasing the complications and consequent cost saving. So if you look into the way how radiation has evolved, if this is what we were in way back in 1940s, this is what we are today. We had made fast forwarded actually a century of gap. All this happened thanks to the digital revolution, which has given us the ability to sculpt the doses in a perfect, precise way. Now, why this is very important? Let me just fly you through this technology advancements. Whenever you're advancing from this area to this area, it's all about margin which we give to the tumor. Now, let me just try to elude you this simple formula which our kids keep telling in the 5th standard. Volume is defined by 4/3 pi r cube. When the radius is increased from 1 millimeter to 2 millimeters, essentially the volume is increased by 8 times. Now, whenever the volume is increased by 8 times, the extra dose which is going into the normal tissue, and that will be disaster. So therefore, you have to ensure in the spinal radiosurgery program how we essentially shrink on the margins. Now, when you're shrinking the margins, you essentially have the ability to hypofractionate the treatment. Now, suppose your case is referred to me, say for a simple spinal metastasis for radiation. Typically, the radiation oncologists give it for 5 sessions or 10 sessions. Here, we are speaking about single session. Patient comes in the morning, gets the treatment done by afternoon, and keeps moving, and that's it. So this is the kind of extreme hypofractionation that we typically do, and all this happens only we have the right tools in place. So putting things into perspective, the broader difference between radiotherapy and radiosurgery, it is more extreme hypofractionation that we use. Typically, it is a single session, but in particular context, clinical context, we use around 2 sessions or 3 sessions. Otherwise, radiotherapy is essentially given for a period of...
Shankar, let me stop you here. Shankar, let me put a question here. Are you trying to say that we are giving low dose and at a specific site, or we are giving a high dose at a very focused site?
So it is a very high dose that we are giving at one specific site to ensure that all the errors, all the margin errors are taken care of. So if you are given low dose of radiotherapy, let's say if we are supposed to give around 40 gray of treatment, right? Typically, the radiation oncologists give around 10 gray per week, which is essentially 2 gray per week, per day. So this is over a period of 4 weeks. Now, if a patient is coming from, say, far away place from Madhya Pradesh, Calcutta, many of my patients come from, all of our patients come from distant areas, which is logistically not convenient. So essentially, you can abbreviate the treatment time, the 4 weeks time, to a single session. That is logistically convenient. It gives results which are much more superior to what the conventional treatment modalities deliver, and more importantly, it will not cause any side effects. So essentially, you're bringing value added service for your patient care cycle. That would make sense.
Earphones.
Yeah. So essentially, here the margins are typically around 1 millimeter. So what we do is cyber knife is something which we use. This is what is there in our Kolaba center, and X knife is something which you see in Borivali center. So cyber knife essentially is a small linac which is mounted on a robot, and I would request all of you to visit us once to see how we are doing. Actually, yesterday we have done one spine SBRT, and tomorrow we have one liver SBRT as well. This is yet another patient who is undergoing treatment on X knife, and this is a different tool. But having said that, cyber knife is one of the best tools which we can use for the simple reason that it gives us a great flexibility in tracking errors during the treatment. Now, spine SBRT is actually intracranial extension of the intracranial radiosurgery, but that is much more complex than intracranial radiosurgery because we have a spinal cord which has a smaller diameters. There are issues of spinal instability, and we need to keep cognizant about the radiation sensitivity of the cord, and more importantly, the cord motion, which you see right in there. We are treating live patients. We are not treating patients who are anesthetized and where everything is paralyzed. We are doing all live patients, and you can see even the resting cord motion which happens consequent to the CSF flow along the cervical and the lumbar curvature where the flow velocity is high. You can see such kind of deviations. Now, when I am putting tight constraints on the spinal cord, what really happens is if this error is not properly taken care of, your patients will land up into spinal cord myelopathy. So essentially, this is what conventional treatment is. You are actually treating the vertebra or the neighboring area, wherever the intended tissue target is. You are actually landing up treating all this area as well. Even the stomach, you can see the pancreas, the kidneys also, a little bit of it, the medial part of it. Every area gets opened up. Now, just because of location, they are coming into the treatment trajectory. So this is the advanced treatment, which is called the SBRT or the spinal treatment, which is highly focused radiation. You can see how beautifully the dose is getting sculpted to the target volume. So essentially, when you're focusing such surgical doses of radiation, your intent is more on to the local disease control, number one, pain relief if the patient has, to maintain the neurologic integrity and also avoid the spinal instability. So the next 15 minutes, what I'll be doing is fly you through the benign cases and the malignant cases. I'm not going to enumerate all of it, only those unique cases which we have done in our clinic and where we have gained some experience. So they are broadly categorized into extramedullary lesions, intramedullary, and column lesions. So the most important primary treatment for any benign spinal neoplasm, hands down, is microsurgical resection. No controversy about it. But in those clinical contexts where the patients are not really the ideal candidates, or because of the age, medical comorbidities, a recurrent nature of the tumor, or whenever we are dealing patients with family phacomatoses, specifically NF1 and NF2, these are the situations where spinal radiosurgery can be used. Now, this is very important. How we delineate the cord is very important. Undoubtedly, MRI is used, but in majority of the post-op settings, we don't use MRI because we have CT myelography, which gives us better delineation of the cords. So interestingly, this is one of the patients who had C7T1 schwannoma. The patient actually had underwent surgery, and then again, this was a post-op recurrence which has happened, and we have done a cyberknife for this patient. You can see 12 months down the line how the lesion has actually decreased. 24 months down the line, you can see a very good regression of the disease. Having said that, recurrent setting, schwannomas, radiosurgery is a good option which can be explored. Similarly, a T9 schwannoma, you can see how highly focused spinal SBRT or radiosurgery can cause a very good regression of the disease. And also it's very important because we are shooting surgical doses of radiation, which impacts the vasculogenesis and causing vascular apoptosis. There will be temporal changes in the enhancement pattern. So we need to be very clear in the post SBRT situation, there will be some changes in the enhancement. The same happens even for the intracranial lesions as well. This is yet another patient who had a very big, this again all post-op recurrences. Again, I'm always telling all the cases which I'm alluding to are recurrent settings and not the navigate setting. They have failed consequent to radiation surgery, and then they were referred to us, and we have done radiosurgery. And this is one of the patients whom I treated way back in 2007 or 8. If I remember, 10 years post-treatment, you can see how beautifully the lesion has regressed to. So it takes some time. It doesn't disappear overnight as what surgeons give instant gratification to the patients. But having said that, this is essentially a non-invasive tool which can be kind of explored. So this is another patient who is neurofibroma, 49-year-old patient presented with symptomatic left C5, C6 neurofibroma with cord compression. You can see right in there. The patient underwent surgical decompression, partial tumor resection, and you can see this is the post-op scan, which the patient actually had some residual, and post-operative period, the patient actually had some residual weakness and radicular pain. We have done radiosurgery to this patient, spinal radiosurgery, and you can see all this clinical complaints were resolved in just 1 month period. And meningioma is also second important indication. Third important indication, this is one of the patients who had pre-treatment meningioma. We have done radiosurgery. Again, this is post-op residual, this was the problem. Patient had underwent surgery 7-8 months back, and then the patient was reluctant to undergo second surgery, and the patient was referred for Cyberknife to us. And we have done radiosurgery, and you can see 9 months down the line, this is how the patient actually responds to the treatment. And the same with another patient who had C1 meningioma. You can see these tumors post radiosurgery, they are really very stable. And if you look into the results in the published results across these different types of indications, the local control rates ranges between 95 to 100%. The second important indication is intramedullary lesions, and AVM, spinal AVMs are an important indication which I would like to draw your attention to. There are different types of AVMs which are situated right in there, which are the spinal DBF, the glomus, the metameric, and the direct. Intramedullary AVMs, the glomus type, are specifically those indications where radiosurgery has a particular role. Embolization is one treatment which can be used, but again, this carries a significant intraprocedural risk. And again, as I said, angiography, obliteration of the nidus is not the necessary goal of embolization. It is essentially a tool to reduce the shunting volume and stabilize the symptoms. So the surgery is always a risky proposition in intramedullary AVM. So radiosurgery is something which can be contemplated. We have done few patients of intramedullary AVMs. You can see the pre-treatment and post-treatment, the patients had a very good response. This is yet another patient who had C5, C6 AVMs. We have done radiosurgery, and you can see how the AVM has got obliterated. So there are different series that we have done. You can see pre-treatment, post-treatment. This was again C5, C6, the same patient. And conus medullaris AVM as well. We can do pre-treatment and post-treatment. This was one interesting patient whom we have consulted probably a few years earlier. Extradural hemangiomas. This was a 27-year-old lady who presented with the surgery, gateless cements, and right shoulder pain. MRI actually revealed some extraforaminal mass, which you see right there. At T1 and T2 and T2, T3 intervertebral foramina, patient underwent decompressive laminectomy, and as you see, histology was a cavernoma. The patient had a cavernous spaces within septa, and again that was positive for endothelial marker. Patient underwent surgery. There was a recurrence post-surgery, and the patient was, the radiculomyelopathy was actually progressing. So we have done radiosurgery in this patient. As you see right in there, this extraforaminal mass was targeted using Cyberknife, and we have delivered around 4 fractions. And you can see the radicular pain has actually disappeared within just few days post Cyberknife. And at 3 months, you can see how differently the lesion has kind of responded. The same is intradural metastasis, intramedullary metastasis. This was one of the patients who had a renal cell carcinoma with bilateral profound shoulder pain and upper extremity paresthesia. You can see pre-treatment, post-treatment, the kind of response which you see right in there. And yet another patient of melanoma who had a heterogeneously enhancing intramedullary lesion, as you see right in there, at the level of C6, we have done radiosurgery and you can see a very good response. We can also do for spinal hemangioblastomas. These are the intramedullary indications. Again, these are all the kind of indications wherever the patient is kind of carrying a risk factor for some kind of surgery, or it can be used in a treatment naive setting as well once the diagnosis kind of established. The last is the column lesions. Now this is very important. History is particularly very important. I need not tell all those things, but whenever there is any mechanical stability, that is the time we advise for surgery. Now, whenever we look at the case, we just try to evaluate the SIN score, typically, which is decided by location, pain, bone lesion type, the kind of spinal element, spinal alignment, the vertebral body collapse, and essentially grade them into different types of 1, 2, and 3. Only in this unstable, that's the time we definitely refer the patient to the surgery. Now we use the norms criteria, specifically mechanically unstable, for stabilize it. If you are having a low grade epidural spinal cord compression, no myelopathy, that is the time we can actually use some kind of separation surgery. So in the context of vertebral metastasis, so whenever you are dealing with a limited de novo solitary or oligometastasis, and this metastasis happen to be radio resistant in a adjuvant or an elective situation, all these situations we can use spine SBRT. Of course, mechanical instability is one thing which contradicts. So if you look into the decision protocol, this is the solitary, 2 contiguous spine segments, or 3 non-contiguous spine segments. All of this can be advised for spine SBRT. So essentially, we look into the gross tumor volume to spinal cord distance. As you see right in there, if it is more than 3 millimeters, that is the time we get away with a single fraction. If it is less than 3 millimeters, we probably give ranges anywhere between 2 to 5 sessions. So CT myelography is something, MRI is something which we use for cord delineation. These are few interesting examples where we typically shoot in a single fraction, as you see right in there, or a multiple 2 contiguous lesions, as you see right in there. This is one of the patients who underwent surgery. Post-op spine SBRT can also be contemplated, and this is very important. So patients with mechanical instability due to radio-resistant tumors without compression of the spinal cord are excellent candidates for kyphoplasty followed by radiosurgery. Now, if you see the SINS categorization, it is stable, potentially unstable, and unstable. Patients who actually present with mechanical axial back pain or without significant fracture extension into posterior elements, they are the kind of potentially unstable patients who get maximum benefit from percutaneous vertebral cement augmentation. Lastly, it is this epidural spread disease grade that's very important. All of you are pretty aware of the Bilski grading, which we use in our clinic. Bilski grade 1 is epidural impingement just without any deformation of the thecal sac. If there is a deformation of thecal sac, that falls into 1B. Deformation of thecal sac and spinal cord abutment falls into 1C. And 2 is essentially compression. Definitely this is the kind of context we advise for surgery undoubtedly. But when the patient actually falls into 1A and 1B, what we can do is do some sort of separation surgery and then go ahead and do radiosurgery. This is one of the patients whom we have done separation surgery, and later on we have done spine SBRT. You can see a very good response which happens post-treatment. This is one of the patients, this is very important, which I would like to draw your attention to. Majority of the times, When you do spine SBRT, you can see results happening within hours after the treatment. This is happening because of the vascular apoptosis which happens post-surgical dose shots. You can see this was one of the patients who had pre-op SUV of 12.77, lung cancer with a disease which is spread to the one of the dorsal vertebra. You can see here there is a large paraspinal lesion. So we have just shot it with probably like 2 fractions of radiation because we had a very large lesion situated right there. Within 3 days, we have repeated the SUV. It has fallen to 4.3. And what you see 4.3 post radiosurgery is essentially the inflammation that is considered to be normal. This patient, 3 years post treatment, is still disease free. And of course, this patient had targeted therapy because it's lung and it was ALK positive. So the patient was put on some kind of targeted therapy like alectinib. The typical kind of imaging based response you can see a complete bone formation, which happens 6 months. Usually it happens around 6 months. You can see will be a very good response. So as I said, some separation surgeries which we contemplate for typically 1A and 1B. Basically, it gives some kind of shortened hospital stay, decreased blood loss, reduced intraoperative. There are different types of separation surgeries that one can contemplate, which is the posterior MIs, the posterior MIs with percute screws and all this stuff. So lastly, it is the cervical chordoma. Specifically, as alluded to earlier as well, in the mobile spinal sacrum, en-bloc resection without preoperative neoadjuvant radiotherapy is something which, if it is feasible, should be contemplated. If en-bloc resection causes a lot of morbidity, pre-op radiotherapy is something which can be definitely contemplated. By any chance, if the patient has positive margins, then definitely post-op radiotherapy is something which has to be planned out. This was a 43-year-old patient who presented with dysphagia secondary to C3 tumor. Biopsy was done. It was chordoma, and the patient, of course, chordoma, everyone knows. Patient radio resistant, then every one of us knows that it's radio resistant. The treatment plan was to essentially do pre-op radiation, hyperfractionated radiotherapy. But essentially, post-treatment, the patient did not undergo any excision because they had subjective improvement. As you can see, this was the pre-op radiosurgery dose. You can see 3 years down the line, there has been a meaningfully significant decrease in the size. So the moot point which I'm trying to tell is radiation is not partly the upfront primary treatment. But having said that, yeah, the surgery is something which needs to be contemplated. Having said that, because these are slow growing tumors, we can also get away with radiation. And whenever there are symptoms of progression, that's the time you can kind of shoot it down. This was yet another patient of sacral chordoma where we have done pre-op radiotherapy followed by surgery. And lastly, it is the vertebral hemangioma. We need to keep in mind whenever it is symptomatic, pain, of course, is there. Percute vertebroplasty or transarterial chemoembolization is something which is very important. Only when there is recurrent pain, that's the time we advocate radiation therapy. And when there is a neurologic deficit, undoubtedly transarterial embolization, decompressible laminectomy, only when there is a residual disease, which is disease right in there, that is the time we advocate radiotherapy. So in short, friends, it's very important. Radiosurgery, spinal radiosurgery is something which is newly evolved, and definitely I'm sure all the indications which I have discussed is few of my series, and it gives a lot of advantages because all those patients, the indications as I alluded to, the intramedullary and the extramedullary, different types of indications, the metastasis, we can have essentially a non-surgical kind of approach wherein we can maximize the results while mitigating the side effects. Thanks much for your patient listening.
Hello, Vishal, we can't hear you. You're mute. Vishal, we can't hear you. You are muted.
Thank you, Shankar. It has been really wonderful to hear that out. And I'm sure, like you just mentioned, future of management of spinal tumors is not going to be the same as it has been so far. And I'm sure more and more cases that we are going to be seeing, which have been managed in the old conventional ways. As we have been seeing more recurrent cases, I am sure this coming decade is going to see more and more recurrent tumors being present into our clinic, and I'm sure the role of radiosurgery or spinal radiosurgery is going to be defined better when we see more of these residual or recurrent tumors that will come to us. Also, I'm sure the spinal radiotherapy will open up doors for prevention of recurrence in future of cases where unblock or wide margin surgeries are not possible, like in patients with giant cell tumor or chordomas, or patients where high spillage has happened, or when unblock is not possible. And unfortunately, it is very common to see such tumors where unblock resection is not possible. And I am sure prevention of recurrence, which is also one of the principles of treatment, will probably be solved with the availability of spinal radiosurgery in city of Bombay with us. And I'm also happy that we have these modalities available to not only reduce the complication rates. I would like to ask a few questions after the questions from other panelists come up. Priyank, you have a question, please.
So I had one question regarding the number of levels. Let's say if we have more than 3 levels, maybe 5 or 6 level metastasis, can we go ahead with SBRT or?
No, absolutely not. So this is what I was trying to tell you.
Yeah.
You're seeing my screen, right?
Yes, yes.
Yeah. So essentially, when you are speaking about radiosurgery, it has to be either a solitary metastasis with some soft tissue, or 2 contiguous spine segments, or 3 non-contiguous spine segments. Suppose you have 3-4 continuously like this, it's really a large volume to get treated. And by any chance, if you're treating a lesion near the cervical spine where the cord mobility is pretty high, you risk the patient with cord myelopathy. So therefore, you need to be extra cautious. As you see right in there, in one of my slides, I was showing you the cord mobility. That is very important. You know, what we essentially do is, what you see right in there, we do, this is on the cine MRI scans that we do for all the patients. What we essentially do is just incorporate that small sub-millimeter motion into the planning system. You know, we need to incorporate this motion properly. Then only we can decrease the incidence of cord toxicity. So essentially, it depends. If we are doing multi-level spinal SBRT, it is usually for 3 non-contiguous segments. Beyond 3, I don't really advise for spinal SBRT, because at that particular point of time, the patient is having polymetastasis and not oligometastasis. Oligometastasis is something which is defined as less than 5 metastasis in the whole of the body on PET CT.
Okay.
PET CT.
Right. Thank you, Shankar. Kedar, you had a question. Please come up.
Yes, yes. Really superb presentation. One thing is, what is the cost of this stereotactic body radiotherapy? Another thing is, if it is so focused, can we give it as a neoadjuvant before surgery, then do surgery? And also with the newer things of proton and carbon ion, how effective is this SBRT as compared to proton and carbon ion?
So one thing, first let me answer the second question, and then I'll come back to the cost part of it. Now, the moot point which you are trying to ask is neoadjuvant radiation therapy. You know, the clinical context where we use neoadjuvant radiotherapy in the context, would be more to the chordomas. That's where we essentially advocate the practice, and specifically more when the lesion is of a larger size and the surgeon has a definite compromised quality of life with increasing morbidity and stuff like that. Now, that is something which we typically follow. Now, second point, otherwise, majority of the times, all the benign lesions which you see right in there are post-op recurrences. And the first frontline option would be definitely surgery in all the cases. There is no controversy about it. Only in those recurrent sittings. In fact, one of the neurofibroma patient I have treated almost 14 years earlier, way back in 2004 or something like that. Patient is still fine now, and that was a very large lesion which was measuring around 5 centimeters, 5 or 6 centimeters. So I explained the patient underwent multiple surgeries, 3-4 times, and in the end they have approached me. I explained them about SBRT at that particular time, and they were kind of, you know, the patient basically stays in Jaipur. They were operated by a surgeon in Delhi for almost 3-4 times, and all the times there was a recurrence. And essentially in a post-op setting, it's an adjuvant. setting, you can actually do radiosurgery. And the beautiful part of this particular tool is you can abbreviate the treatment in 1 day or 2 days or 3 days. People don't mind coming. Majority of my patients, I get few of my international patients as well. They come in the morning, tomorrow they take the flight and keep going. So it is more adjuvant setting in majority of the extramedullary lesions. Intramedullary, it can be per primal. And vertebral, typically, if there is mechanical instability, that is the time when we get adjuvant. Neoadjuvant, we really don't do. It will be direct primary modality for metastasis. Now, coming to the second question, where radiosurgery goes over proton or carbon therapy. This is something which is very important. Every surgeon needs to know. Now, we are comparing two tools. Number one is the radiosurgery. Radiosurgery is an abbreviated format. It's like a T20 and a test match. T20 is something you just play in just a couple of hours and get the results. Unlike a test match, which is played for 5 days. Now, whenever you're using proton, proton is a very big problem. It is a wonderful tool, but the cut is very sharp. Now, proton really doesn't factor in all the sub-millimeter dose movement which you see right in there. This is a patient who's actually swallowing, and every person on the planet swallows 3 to 4 times a minute. And whenever the patient swallows, there is a movement of the cord and the entire posterior cervical system. So what really happens is there will be errors during the treatment. So therefore, radiosurgery is something which is not actually contemplated in proton. So what really happens is you can use it for very selected indications. Whatever frame of diseases that I have shown right now, you can just Google and see wherever radiosurgery was done. It was not done on proton. It was done on a saber knife or an X knife. Basically, these tools are much more advantageous, and it offsets all the errors, and the tools which are available with us are much, much more, robust with regards to the real-time tracking, which is not missing, which is kind of missing in the protons. Right. Therefore, what happens if you send this patient for a proton treatment, they cannot treat in a single fraction, because organ motion is something which cannot be corrected. It happens during the treatment. Now, typically these patients receive three weeks or 1 or 4 weeks kind of treatment. Now, when a patient goes from here to other place, stays there, and more importantly, beyond anything, it's a financial toxicity of the patient. I cannot afford a proton treatment as of today. No insurance company will reimburse. It costs around 30-35 lakhs in a private sector. I'm sure once data comes up, then probably that also is not subsidized. That is subsidized to probably anywhere between 7.5 to 15 lakhs, but it is not totally waived off. Again, only those patients who are in research protocol in Tata Memorial, they are kind of waived off the charges. But having said that, we need to understand, you have better tools right there, abbreviated format, a tool which gives us real-time tracking, tool which gives us all the logistic advantage, which decreases the financial toxicity. What else you want essentially?
Cost, Shankar.
Cost. Yeah, I'm giving you a comparative cost. So on a proton, it will be something like 30 lakhs. On a saber knife, it will be around 4.5 lakhs. So essentially, if we are doing it in a single fraction, it will be around 3.5 lakhs. If we are doing it in a multi-session format, it will be around 4.5 lakhs, 4.5 to 5 lakhs. That is
okay. Bombay Spine Society has plenty of poor patients, I am sure. To begin with,
no issues. Vishal, just take your phone and call me, anyone out there. Don't worry about the cost. At the end, if you have any poor patient, just ping me. We'll take care of it.
Thank you, Shankar, for offering.
So, Vishal, just one quick question.
Yes,
Vishal, just one quick question. Yeah. Which centers in Mumbai and Pune are offering spine SBRT?
So I have been practicing since last 17 years, spine SBRT and intracranial or extracranial across liver, spine and all. In Mumbai, we do it. I have seen a few cases, probably in KDH. In Tata Memorial, they do it. And no one else does it. In Mumbai.
Pune? In Pune?
Ruby Hall, I have seen. Ruby Hall is one case, one place which can be done. But
Okay.
again,
Shankar, one quick last question now coming up from Manish. Manish, our panelist. Manish, do you have a question for Shankar?
Yeah, Dr. Shankar, fantastic presentation. Just one quick question. How much does the presence of a metallic cage, like very close, sometimes it ends up very close to the cord as well, affect your SBRT? Are you worried about scatter or your ability to give flow?
It's a very interesting question that you have asked, Manish. Really appreciate the attention you had. Now, this is very important. So whenever you are having some kind of fixation right there, so when we are shooting the beams, we try to avoid this fixation device. We just don't go through the fixation device because there will be a little bit of scattering which you see if the beams go through the fixation device. So we essentially don't want to, suppose we are sure, so what we do is we delineate the fixation device also during the treatment, and we ensure that the beams avoid that particular trajectory. And on a cyber knife, you have around 1400 trajectories which can be used to shoot the disease. Unlike a X knife, you have around 300. So therefore, if we have 1400 direction trajectories with which I can shoot the disease, you can avoid this particular area, the instrument, which you see right in there. Now we try to contour it, and we also try to remove it from the beam path just to ensure that beam path toxicity is decreased, because there will be some local deposit of extra dose which is going to happen. And sometimes, there can be some skin reactions also. I haven't shown that particular, because I am asked by Vishal to just restrict it to 20 minutes. I thought I'll give you a bird's eye view of the indication part. And of course, if you are using instrumentation, you have to ensure that this side effects, to keep the side effects very minimal, you have to avoid placing the beam through the instruments. That's the moot point.
Right.
So would you suggest us surgeons not
One
to
last
use a
question
cage?
from me. Yes, Manish, please.
Would you suggest us surgeons not to use a cage or use a bone graft or a bone instead? Or are you still okay having a cage there? As it given an option?
So this is what, whenever you are having this particular kind of context, patients with mechanical instability due to radio-resistant tumors and without compression of the spinal cord, you can do some vertebral cement augmentation. I have no problem. You can go ahead and we can do radiosurgery. It doesn't tamper our results.
Last question, Shankar. So it is said that conventional radiotherapy usually should be given after the surgery, because that leads to infections if done before the surgery. So does that apply to SBRT also? Why I'm trying to say is that if SBRT can help us by reducing the operative complications and at the same time pre-operatively shrinking the size of the tumor, will be of great help, and if it is not adding to the complications of surgery. Can you enlighten us on that?
So one thing, I was just wondering, Vishal, what is the clinical context you are thinking in your mind when you are advising?
So a chordoma or a GCT often comes to us with pathological fractures.
You do not have any intra-op problems post SBRT, because the margin which we use is just 2-3 millimeters. It is just suffice to take care of the clinical target volume.
So skin infection rates are not high with SBRT before surgery?
It will not, because there will be, these are highly targeted surgical doses of radiation that get hit. You will not have any collateral doses which get deposited. Typically, we are delivering surgical doses of radiation. In fact, for rectal cancer, we are delivering 5 gray times 5. Means it's like 25 gray times 5, and its biologic equivalent dose is around 50 gray, 50 to 55 gray. The surgeon does the surgery in the next week itself. Suppose the patient
and just to supplement this, what is the collateral damage to surrounding structures when we are doing vertebral column tumor SBRT?
So essentially, it depends again. I'm sure it is a different presentation. If you want, I can show it to you now itself. But
it has been
just fly you through, because last week I gave a lecture on. Let me just pull out that presentation, Vishal. A couple of minutes, if I can get.
If you can just tell us, maybe we are already running. There is an overlap of webinar that's going to come up on Ortho TV. We have to close now.
So basically, you need to keep in mind vertebral compression fracture is something very important. VCF is something very important. Now, VCF is something which happens in around 20 to 30%. Again, it depends. Preoperatively, if there is any, one second, let me just pull out, you will get a better idea. So basically, you need to keep in mind it's a VCF, the cord myelopathy, which is very important, the spinal cord, which you need to keep in mind. There will be a transient increase in the pain, which happens, which it is more because of the nerve sheath edema. And lastly, you need to keep in mind, suppose you are radiating a thoracic vertebra doing radiosurgery, you have to ensure that the doses to the esophagus is very less, kept as low as possible. And sometimes, as I said, in instrumentation cases, you need to minimize the doses to the skin. Otherwise, these patients usually will end up having some skin reactions which are consequent to the Vishal, I've just opened the presentation. Can I just share it? One second. Yeah, I've just shared it. This was a talk which I've given just last week. We had a spine SBRT seminar, webinar. Yeah, so typically, as you see right in there, it's the vertebral compression fracture. This is how it looks like, the vertebral compression fracture. And definitely the alignment is very important, the type of lesion and the age. These are the kind of risk factors, the best predictors of the vertebral involvement, the osteolytic element, volume, and all the stuff. And of course, the mechanism, I'm not going to just concentrate on it.
Right.
And of course, you need to keep in mind the cord myelopathy, how we decrease it, and also this is the skin reactions which happen. You know, if you are treating usually lesions which are in the posterior elements and post instrumentation, you see how the skin reactions keep happening. So this is something which you need to keep in mind when you're treating, and sometimes you can have some plexopathy as well. Again, all these are very transient, and esophageal toxicity when you're treating lesions which are close to the thoracic column.
Right.
So
I think that takes us to the closing day or part of the session. It has been really wonderful. We started with the most simplest of tumors when we saw Priyank presenting his case. We saw Kedar coming up with the most complex of cases, chordoma at the lumbosacral junction. We saw some really innovative ways of managing these tumors with supervised masterly neglect, like Priyank mentioned, in patient with ABC. We saw Dr. Sameer Dalvi showing a newer and adjuvant method of treating a giant cell tumor, where Manish and Sameera mentioned a role of prolonged follow-up and observing these patients on medical management. We also heard about the feasibility of unblock resection, the need of unblock resection, and all the principles about managing these primary tumors, where the primary role is not only to diagnose these tumors well in time, have a very high index of suspicion, because most of these tumors will not have specific symptoms. They will surely not have specific radiological findings. All these tumors will present to you with very subtle mechanical symptoms, rarely neurological symptoms, and very, very common misleading radiological findings. And it's only your high index of suspicion that will help you to diagnose these tumors. And to diagnose, spinal biopsy is the only gold standard. There is no substitute to spinal biopsy. Whenever you see a spinal lesion, unless until you have a biopsy, you'll only be assuming and playing around and will be misled to treat these patients. And poor diagnosis can lead to a disaster situation. When treating these patients, remember, Pre-operative investigations like MRI, CT, and PET CT scan are absolutely mandatory to understand the grade, level, and type of tumors. And also, when you plan the tumors, it's your role, it's your duty, it's your responsibility to reduce the morbidity. Sometimes embolization is absolutely mandatory. Embolization can also be therapeutic in some tumors like hemangiomas and GCTs when done in a sequential manner. Even in ABCs, they have an important role to play. Medical management of these tumors can really change the whole course of these treatments if done pre-operatively. When surgery, optimal decompression, of course, takes the precedence. However, resection of the tumor with clear margins, ideally en-bloc resection, reduces the recurrence, and the whole chance of having a good outcome will be in your hands when you do these surgeries the way they are supposed to be done. Sometimes after resection, the defect reconstruction can be a challenge, and that's why preoperative planning is something that should always be kept in mind. After reconstruction, again, a long-term follow-up is absolutely mandatory in all these tumor patients, because these primary tumors can have a very slow course of progression and recurrence, and sometimes can recur, as Dr. Mihir mentioned, can recur up to 20 years down the line also. We saw some implant failures, we saw some problems, we saw some complications of tumor management. And of course, the role of SBRT in not only prevention of recurrence in these tumors, but also in treatment of residual and recurrent tumors is very, very handy. In metastatic patients also, in contiguous diseases, SBRT comes very handy, and I am sure we are going to utilize the services of Shankar from HCG in near future also to get better outcomes for these patients. Thank you, Shankar. At the outset, I would like to also thank Dr. Sameer Dalvi, Dr. Mihir Bapat, Kedar, Priyank, and Manish. Thank you so much for being with us and sparing your time to enlighten us on the one and only session on spinal tumors in the last whole 1 month. Thank you so much for joining us. But nonetheless, before we end this session, it could just not have been possible if Ashok and Neeraj didn't give us the patient hearing and the time slot on Ortho TV for 2.5 long hours. Take my word, this is the longest seminar that they have given the slot for. Ashok, I really, really am indebted, and thank you so much for doing this for us.
Thank you very much. It was really very interesting, and a lot of points were covered in the entire 2.5 hours. I'm sure a lot of people are going to rewatch it. We had more than 1150 viewers for this webinar on Ortho TV, and another, I think, 200 on YouTube also. So it was an amazing session.
Thank you.
Thank you. Lastly, I would like to thank our sponsors, Sun Pharma, makers of Hydroforce and Bonista, for supporting us. Thank you very much.
Bombay Spine Society, thank you so much for allowing us to be on.
Thanks, Vishal. Thanks a lot. Thanks a lot.
Thanks a lot.
Thank you, Vishal.
Thank you, Kamil sir. Thank you so much.
Bye.